Yes, madam. Yes, madam.
Our Prashant from St. John's is talking about intubation and medication. So you can just mention that as
Yeah,
well.
coming there, madam. So today's
Yeah.
session will be moderated by Prashant from St. John's, who will be talking on the topics of Chandrakala madam together with her. So on behalf of NF Karnataka, Prashant, warm welcome to you as well. So now the recording has
Thank you,
started.
sir.
I request Sahana madam to start the program. Over to you, madam.
Yeah, thank you so much, Prashant, for that kind introduction. And I'm so happy. And my dear, good afternoon to my dear friends, teachers, seniors, mentors, and fellow pediatricians, and my dear PG students who are all watching this. And this is a very important topic which is close to my heart. When Dr. Prashant and Dr. Dinakar, I should give special thanks to NNF Karnataka and special thanks to Dr. Prashant, Dr. Dinakar and Kotreshi sir and Ranjan sir, because I started off the NRP program in after NSSK program, that is Navajata Shishu Suraksha Karikram in 2008, and we started off in all over Karnataka. I started with Dr. Ranjan sir, then followed by Kotreshi sir. And 2 days ago, when Prashant and Dinakar called me, it was a surprise call. I was outside. And today I had a family get together. I had to cancel it because this is close to my heart. I cannot say no to neonatal resuscitation wherever, whenever, that is very close to my heart. And so thank you so much for this wonderful opportunity, and especially because with my colleagues, always me, Janaki ma'am and Chandrakala used to go together to Chikbalapur. We used to make a cab and go, and along with some more people like Archana, and many of them used to come. It was a wonderful experience, and I love this program. And why we have to know about neonatal resuscitation, and I think this is the first time on a virtual platform we are doing this. Usually this is a hands-on training and with active participation of the delegates. So this is the virtual platform. I don't know how it will go about, and because it's a whole day program from morning 8 till 6:37. So with 4 hours, I don't know. Without much ado, I'm going to start. And why this neonatal program we are doing, and everybody, it's our duty, birth of a newborn is a potential medical emergency, and all babies need assessment for resuscitation at birth, and the need for resuscitation at birth cannot be anticipated, and all equipment should be ready, and it should be functional, and with all the standard precautions, like all resuscitation should be conducted under strict asepsis, and all resuscitation apparatus wherever possible should be a disposable one. So hence, why we have more worried about neonatal resuscitation? Because over 1 million babies are dying all over the world due to perinatal asphyxia. So perinatal asphyxia is one of the important causes for neonatal mortality and morbidity. Even our country accounts for 1/3 of the major chunk of these neonatal mortality, which is around 1 lakh 3 lakh children, babies, newborn babies are dying of perinatal asphyxia. And it is with this good, beautiful program of neonatal resuscitation flow diagram, we can reduce the the resuscitation, we can reduce the burden of perinatal mortality. And we are not just worried about the survival of the neonate, but intact survival is what we are going to do. And this first golden minute project of IAP and NNF is a wonderful program. That is, you should never do no harm. It is the duty of everybody who takes care of the babies should learn about neonatal resuscitation program. It is not only for neonatologists, nor the pediatricians, nor the postgraduate students, and it is equally important for the anesthetists and the obstetricians particularly, and the nurses also are important. And without knowing, just knowing the knowledge, we should have this ethics when we take as a become a doctors, that is primum non nocere, first do no harm, by Hippocrates. We have to follow this. So coming back to neonatal resuscitation, our dream is to give a breath and save a life. So overview, I'll be covering about bit of physiology, then preparation of NRP, how we go about, then initial assessment, routine care, and the initial steps of resuscitation. So why should we learn about resuscitation? About with the appropriate resuscitation, outcome of thousands of newborns will improve, which I was talking about, intact survival. And although by God's grace, most of the babies will have normal transition from extrauterine life to intrauterine to extrauterine life, about 90% of the cases. Whereas about 4 to 10% of the babies will require some resuscitation, including a positive pressure ventilation. And only 1% of the times you need extensive resuscitative measures like chest compressions and the drugs. So why newborns? How newborns are different in resuscitation approach than adults? So when an adult has an arrest, that is cardiac arrest, most often it is due to a cardiac cause, that is due to a myocardial infarction or some ventricular tachycardias or arrhythmias. So here chest compression takes over, and that's the reason there is a slight difference between a CPR of an adult and a newborn. Whereas newborns usually will have a normal functioning heart. Whereas the problem is with the respiration and the gas exchange. Hence, ventilation is the most important step in effective ventilation, is the most important step in neonatal resuscitation. Why do we need protocols? Because we need to give uniform care, and the standard of care should be the same wherever baby is born, whether baby is born in a PHC, whether baby is born in a medical college or a corporate hospitals. The uniform protocols have to be followed, and to provide quick and effective interventions at the required time. So coming back to fetal physiology, let's know about, all of you know about this, just a brief about fetal physiology, that is before birth and after birth. So what happens in fetal physiology? Fetal circulation, that is only a small amount of the blood travels to the lungs, and there is no gas exchange in the lungs. So everything is taken care of by the placenta. Placenta takes care of the baby's breathing, circulation, everything. So blood returning to the right side of the heart from the umbilical vein through the ductus venosus goes to the ductus arteriosus, and right side of the heart has got the highest oxygen saturation. Whereas after birth, that is postnatal, once baby is born, there is a transitional circulation pathway. Once the baby takes a breath, the pulmonary resistance decreases, then the blood travels to the lungs through the pulmonary vessels. So gas exchange occurs at the level of the lung. So blood returning to the left side of the heart from the lungs has the highest saturation. So here, because the 3 cardinal changes occur during transition. Once changes at the birth, the baby breathes, the cord is clamped, then which results baby uses the lungs instead of the placenta for the gas exchange. And whereas before birth, the alveoli is fluid filled, and which gets absorbed once baby is born. Air replaces the fluid in the alveoli and gas exchange takes place. One more thing is, air in the alveoli causes the blood vessels in the lungs to dilate, which helps in pulmonary blood flow increases, and the ductus starts constricting. So baby comes from the fluid-filled womb to an air-filled room. So these are again, as I have spoken, with each initial breath, it takes 3 or 4 breaths for the complete replacement of the fluid alveoli, which is fluid-filled to air-filled alveoli. So pulmonary vessels, what happens before and after birth? This I have already told. Blood vessels are constricted as because of the fluid in the alveoli. And once the baby is born, that is oxygen is replacing in the alveoli, and dilated vessels, the pulmonary vessels dilate. So complete transition is a long process, though, because it takes 10 minutes to reach the saturation SpO2 of 90% for a newborn baby, and several hours for the alveolar fluid to get absorbed, and 2 to 3 days, as we know, the duct will be open and it takes for the functional closure of the duct, whereas several months for the complete relaxation of the pulmonary vessels. So what can go wrong during this transition? One is breaths not forceful. to remove the alveolar fluid, or a foreign material like a meconium can be block the airway, and when oxygen is not available for the gas exchange. And excessive blood loss, as in a sentinel event, mother can come with an abruptio placenta or a placenta previa or a cord prolapse, and there is poor myocardial contractility which causes systemic hypotension, and there could be a hypoxia as a result of constriction of the pulmonary arterioles, which causes tissue oxygen deprivation, what we talk about PPHN. And in utero or perinatal compromise. So respiration first to cease. What happens when there is some problem with the transition? The respiration first to cease after the oxygen deprivation. So baby goes into primary apnea, and what happens in the primary apnea? Initially there is rapid breathing, and then baby goes for, after that baby goes for a brief apnea, that is irregular breathing, and then goes for a secondary apnea. So what is the physiology of asphyxia here? Primary and secondary apnea. In primary apnea, baby has a rapid breathing followed by bradycardia and primary apnea. In this situation, just stimulation of the baby can help. Whereas followed by this, there is irregular gasps, and baby goes into a secondary apnea. During this period, there is mean arterial pressure goes down, the blood pressure falls, and during this time, the stimulation of the baby will not help, and baby requires a positive pressure ventilation. So any baby is born with apnea, think as secondary apnea. So how does a newborn respond to an interruption in normal transition? This is what I have already explained. Baby goes for tachycardia, then bradycardia, muscle tone is reduced, and low oxygen saturation and a low blood pressure. The main focus on neonatal resuscitation today is ventilation of the baby's lung is the most important thing. So coming back to the whole of today, we'll be talking about the NRP flow diagram. If you cannot see, we'll be discussing each of these steps separately. Don't worry if you cannot see, it is a crowded one. But this NRP algorithm or a NRP flow diagram, all of us should be in the same page. So what happens in this is there are 5 blocks which are beginning after birth and initial assessment. There are diamonds and rectangles. Diamonds indicates the assessment, whereas rectangles indicate the action, what we are supposed to do. And we have to analyze these babies in this format, that is initial steps, airway, breathing, circulation, and drugs. Initial assessment, when the baby is born, we'll have to see whether baby can be with the mom itself or baby requires any resuscitation. And coming to airway, whether baby's airway is open, whether there are any secretions, airway can be blocked, you need to do a secretions, there is suctioning of the mouth. When it comes to breathing, it is positive airway pressure either by ambu bag or a T-piece resuscitator. And coming back to circulation, you can, because to augment the heart rate or cardiac pumping, you need to do a chest compression. And last but not the least is the drugs, where the only drug used in resuscitation is adrenaline. My colleagues will be talking about it. And maybe NS can be used. And after each step, this is blocks. You after finishing each block, you have to go to the next block. You cannot just maintain the airway. Before maintaining the airway, you cannot jump into circulation, or without maintaining the circulation, you cannot go back to the drugs. Okay, and then I'll be talking in detail in a next chart. So the main focus on teamwork is important in neonatal resuscitation. Effective teamwork and closed loop communication are the essential skills during neonatal resuscitation. Because many studies have been done, poor teamwork and communication were the most common root causes for potentially preventable infant deaths in the delivery room. So the whole of today will be talking about focusing on the teamwork and communication skills. Most often in a emergency situation and a stressful situation, when baby is delivered, when baby is not breathing, it's really a stressful situation. Hence, we need to do together with a good teamwork, the outcome will be better. pre-resuscitation team briefing. There are 10 key behavioral skills are there, and among them pre-resuscitation team briefing is very important. Before they call, the obstetric provider calls us for a call, we are supposed to have a pre-resuscitation team briefing. So we'll have to assess about the potential risk factors, identifying a team leader, delegating the tasks, and identifying who is documentation is very important in this medico-legal era, and to know how the quality of improvement and for clinical decision making. Determine what supplies and equipments, that is preparation of the supplies and equipments will be needed, and identifying whom to call for an additional help. So this pre-resuscitation debriefing is almost taken from the that is pre-flight with the pilots, you know, when there is a aircraft pilots, when he does a pre-flight check, even though he has flown many a times, so he will do the pre-flight check to ensure the passenger safety. The same concept is taken here to have the patient safety. So we'll have to check all these things to have a good patient safety. So post-resuscitation team briefing. Briefing is before pre-resuscitation, and after resuscitation we'll have to do a team debriefing. This is not to find faults with us, but this will immediately we'll have to do a team debriefing so that it reinforces good teamwork habits and help to identify areas for improvement. So when you face in a similar situation the next time, smaller things or smaller changes will have a good impact and a good outcome. So these are the NRP key behavioral skills. So first one is the know your environment, use all available information, anticipation and planning, clearly identifying a team leader, communicating effectively, delegate the work optimally, allocate the attention wisely, use all available resources, call for additional help when needed, and maintaining a professional behavior. So what are all these concepts? So knowing your environment. So when you come to an environment, your labor room or a OT, so you will have to do a pre-equipment check before the baby is delivered, not after the baby is delivered. You cannot call out, I need an ambu bag. So you'll be in a stress situation. So that first golden minute will be missed. So that in that concept, so you'll have to do a pre-resuscitation check before the baby is delivered. You should have a quick checklist next to the warmer. Always this helps in quickly checking, that is after delivery and before delivery, and after delivery also you should see that everything is in place. Know the location of the resuscitation equipment. Suppose you need a TPS resuscitator or a CPAP, delivery room CPAP, you'll have to know where it is available, or when you have to know about the umbilical catheter, you should know where it is, how to ask, whom to ask. And you should know how to call for help if advanced support is required. Suppose a preterm delivery is there or a multiple gestation is there, you need 2 teams. So you should know how to call for or to activate an emergency system or call for help. Then use available information. So know the prenatal and the intrapartum history, including maternal complications or maternal medications and other risk factors. That's why always you should have a good communication rapport with your obstetric colleagues, though most often we'll be fighting. Okay, so but this will have a good outcome for the babies. And anticipation and plan. Most of the deliveries, you can anticipate this baby will need help. Sometimes it is not possible. Suppose you know the antenatal risk factors or intrapartum risk factors, you can make out that this baby can be anticipation, but during every birth you have to anticipate and plan. Perform a pre-resuscitation team briefing to ensure all team members know the clinical situation. And assigning roles and responsibilities are important, because multitasking will not help in this. So individually, they will have to take the roles and responsibilities. Discuss an action plan in the event of a complication, and clearly identify the team leader. So here the team leader is very important. He need not be the senior most in age or his designation or with the highest degree, need not be a HOD or a professor. I am the professor, I am the HOD. No, even the nurse can be a team leader or a senior resident can be leader, but he should have certain qualities. He should know the NRP flow diagram very well. He should have leadership skills, and he should have a good communicative skills. That is, he should have the clearly articulate the goals and delegate the tasks as appropriate while monitoring and distribution of the workload. That means to say one person cannot have the chest compressions and the drugs. So one person should take care of the chest compression, the other fellow can do the drugs. So include the team members in assessment and planning. So if we are going wrong, you can listen, because I'm a leader, I'm not the boss. So the other person can say that, oh, we could have done this, and to improve that. And think out loud. You should have a broad view the leader should have a broad view. And maintaining the situational awareness is very important. And suppose he takes over any skill, suppose he wants to do the umbilical cannulation, a leader wants to do that, so he can hand over the leadership role to another qualified team member, so that everybody in the team should know that the other person is a leader now, and so that he should tell it aloud. Communicating effectively. Communication is very important in this era of 2021 we are going into. You are called team members by name, share the information actively, inform your team that if you have identified a problem or an error, if there could be a medication error or some error in the safety, in patient safety, in the concern of patient safety, and order medication by name, dose, and the route. Very important. You can say it aloud so that all the other members also will know that you are giving whether drug, adrenaline, 1 ml or 3 ml of adrenaline intratracheal. So you can tell it loud, and use concise, clear language, not the jargons, and use closed loop communication. When it comes to communication, closed loop, what I mean to say, I will say, Dr. Megha, you take care of the positive pressure ventilation. And she will come back and say that, Dr. Sahana, I'm going to take care of the positive pressure ventilation. So that closes the loop. So that is very important. And verify the information, ensure that changes in the information or assessments are shared with all team members, and include, very important, now we are talking about family participatory care, include family members in communication as appropriate. So you have to talk even before the delivery, you have to go and talk to the antenatal counseling has to be done. Suppose there are risk factors like a preterm delivery regarding the surfactant need for ventilation, etc. And if you are suspecting a perinatal asphyxia, because asphyxia is devastating even to the family, so you will have to talk about baby might have asphyxia, might need a cooling, etc. So you have to talk to the father and other bystanders. So delegate the work optimally, do not duplicate the work, and use more resources than necessary. Change the task assignments depending on the skill sets. Suppose one person is good in a umbilical cannulation, so he will take over that. Suppose one person X is good in the intubation. I need not say that I am the boss, I will do the intubation. The person who is, because my PGs will do better intubation than me, because they'll be doing routinely every day. And what is required at that moment. Do not allow one person to become overloaded with the tasks, because multitasking will reduce our quality of care. And do not allow the team to become fixated on a single task. Suppose he has done that, he can help in the other task too. So allocate the attention wisely, maintain situational awareness by scanning and reassessing the clinical situation frequently. Monitor each other's skill performance to ensure patient safety. Suppose I have tried once or twice intubation, I need not have to do the third time, the other person can take over. So it is like that. Use available resources, know what personnel are available, know what additional or special supplies are available, and how to activate it. Call for additional help when needed. Anticipate additional help in a timely manner. Know how you will call for additional help and who will call for that help, and the team should be there. He should not be at home or gone for coffee or elsewhere. He should be in the NICU so that you can call them as early as possible. Maintain professional behavior, very important. Use respectful verbal, non-verbal communication. Actively seek and offer assistance. support and promote the teamwork. Don't snub the people. You did this, the baby became like this. You know, we cannot comment like that. Respect and value your team. Coming back to many a times you can anticipate, suppose there are antepartum risk factors and intrapartum risk factors. Some of the antepartum risk factors like gestational age, suppose it's a preterm less than 37 weeker or greater than 42 weekers postterm, or a mother with a preeclampsia or a diabetes or fetal anemia, polyhydramnios, oligohydramnios or IUGR, and the mother has come for the first time without any antenatal care. Many a times during COVID, none of the mothers have come for a follow-up. So in that situation, that is again a risk factor where you can anticipate some problem. When it comes to intrapartum risk factors, some of the common ones are emergency C-section, then forceps or a vacuum-assisted delivery, breech or abnormal compound presentation, category 2 and 3 fetal heart rate pattern, and maternal GA or magnesium sulfate, then abruption like a sentinel event, cord prolapse, intrapartum bleeding, chorioamnionitis, and meconium stain like a can be some of the intrapartum. When we know these things, we'll be ready. Many a times patient comes and delivers, like in our hospital, we have about 79 deliveries on 23rd of November on a single day. It's really, a mammoth task. So when you're on call at your hospital, you get a call from a delivery room from your obstetric colleague. So pre-delivery, you have to ask 4 questions. Pre-birth questions. After birth, you have 3 questions. Before birth, we'll have 4 questions. This has to be done definitely in all the cases. So you will have to ask your obstetric provider, what is the expected gestational age, whether amniotic fluid clear or amniotic fluid is meconium stained, and whether a singleton or a multiple gestation or a triplet, and any other additional risk factors like a PIH or a diabetes, etc., maternal rheumatic heart disease, etc. So what personnel should be present at delivery? Every birth should be attended by at least one qualified individual who can take care of the newborn care till the positive pressure ventilation. If suppose we have risk factors, at least 2 qualified people should be present solely to manage the baby. The number and qualification of personnel will vary depending on the risk, number of babies and the hospital setting. And a qualified team with full resuscitation skills, including intubation, chest compression and emergency vascular access and medication, should be identified and immediately available for resuscitation when called for. So this pre-resuscitation equipment checklist has to be done routinely at all the deliveries. So this warmth, that is TABCD, we talk about. Temperature maintenance is very important. Hence, maintaining the warmth throughout, that is warm chain, what we talk about, is very important. Preheated warmer, the warmer should be switched on at least half an hour before the baby comes there. Baby is delivered, usually in a manual mode with 100% heater output. With 2 or 3 warm linens have to be kept, and temperature sensor cover for prolonged resuscitation, and a cap, because head is a large surface area, baby loses heat by evaporative heat loss. So you need a cap to cover the baby's head. Suppose you are expecting a baby gestation less than 32 weeks, you need a plastic bag or a cling wrap or a thermal mattress, depending on where you are doing it. And clearing the airway. Next is clearing the airway. You need a bulb syringe, or if you have a foot wall mounted suction, you should see that it is adjusted at 80 to 100 millimeter of mercury, and you should have a suction tubes of 10 and 12 French catheters, and meconium aspirator is optional. And for auscultation of the baby, the best way is to stethoscope. Now in the new addendum, I think your EKG with 3 leads. And ventilation, we need a flow meter set at 10 liters per minute. Oxygen blender, always you cannot give 100% oxygen, is bad for the babies. So you need a oxygen blender with air and oxygen mixed, which has 21 to 100%. And you use room air resuscitation for all babies more than 35 weeks. And Professor Ola on Legends, all of us have listened to him. He's a pioneer in this. And less than 35 weeks gestation, we have to use 21 to 30%, depending on the target saturations. And for ventilation, most important equipment in our armamentarium in neonatal resuscitation is a positive pressure ventilation device, and term and preterm masks have to be kept, that is 0 and 1, and 8 French feeding tube and a large syringe. Suppose baby needs a prolonged positive pressure ventilation, so the stomach gets distended. To vent the air, we need to put a 8 French feeding tube for a term babies. And oxygenation equipment to give free flow oxygen. Pulse oximetry is very important with a sensor and a cover, and target saturation table should be a ready reckoner there. And intubation, laryngoscope with the size 0 and 1 straight blades, and 00 is optional again with a stillet optional, and endotracheal tubes 2.5, 3 and 3.5, 4 is out. And for babies less than 1 kilo, 2.5, 1 to 2 kgs it is 3, and 2 to more than 3 kgs it is 3.5. And carbon dioxide detector, measuring tape and endotracheal tube insertion depth table can be kept at the OT or next to the resuscitation table. And waterproof tape and for securing the ET tubes, and scissors, and laryngeal mask with a size 1 and a 5 ml syringe. And coming to the last but not the least, medications. Access to only drug which is used in resuscitation is adrenaline, and 1 in 10,000 you have to take 1 ml of the 1 in 10,000, make it ready with 9 ml of the normal saline, and it has to be freshly prepared. And whether it is for intratracheal or a UVC, you will have to label it correctly so that we'll be giving the different doses for both. Supplies for placing emergency UVC catheters and administrating medications, and EKG with a 3-lead EKG is again has to be kept. So coming to preparation before birth, we have to anticipation, adequate preparation, timely recognition, quick and correct action. Okay, assessment of perinatal risk factors, 4 questions before delivery, we know that we have discussed. Then form a team with a team leader, team pre-resuscitation team briefing has to be done, and maintain the room temperature, switch off the fans, switch off the ACs, and the delivery room temperature, as you can see, it is showing around 28. It should be 26 to 28, and a quick equipment checklist from head to foot. Then universal precaution, because we cannot forego our hand hygiene, and all things has to be standard precautions, aseptic precautions have to be done during resuscitation. Otherwise, we'll be giving sepsis during resuscitation. Then antenatal counseling is to be done to the parents. Initials, coming back after preparation, initial assessment have to be done, antenatal counseling, team briefing, and equipment check. Once the baby is born, before baby is born, we had 4 questions. Once the baby is born, we have 3 questions. What are they? Whether baby is term, whether the tone is good, breathing or crying. And if the answer to this is yes, baby stays with the mother and goes for a routine care. There, warming the baby, maintaining the normal temperature, positioning airway so that baby cannot be more flexed or extended, and then clear secretions if needed, dry and ongoing evaluation of respiration and heart rate has to be done. If the answer to this is no, then we'll go to the next, that is triangle, warm and maintain the normal temperature, position the airway, clear secretions if needed, dry and stimulate. And evaluation after that, if the baby improves, baby goes to the mother's side for observation care. If the baby has a good respiratory effort, spontaneous breathing, heart rate is more than 100, baby is breathing well. Otherwise, if baby is apneic, gasping or heart rate less than 100, then it goes to the next, that is baby goes for a positive pressure ventilation. If suppose baby has no apnea, no gasping, heart rate is more than 100, but still baby has labored breathing and a persistent cyanosis. So in this situation, you will add a pulse oximetry probe to the preductal, that is right hand, then supplemental oxygen if needed, and we'll consider CPAP, and then post-resuscitation care and the team debriefing. So after this is again a recap of that. After birth, 3 questions. Baby cared on the mother's abdomen, and importance of routine care is delayed cord clamping at least for 30 to 60 seconds later. So that has got a lot of advantages. Neurodevelopmental outcome is better. Then the anemia of infancy is reduced, and more so for preterm babies, lot of other things are there. Skin to skin contact, it is not just put the baby on the mother's abdomen, take it out. It is for exactly 1 hour, or preferably shift the baby, and a bystander can be there. If you are busy, you allow the birth companion to hold the baby. She will start feeding the baby. So that prevents hypothermia and hypoglycemia. Baby starts feeding. So that has got good impact on the, in fact, even the sepsis is prevented. So skin to skin contact for 1 hour, and preferably shift the baby and the mother in the same skin to skin contact to the after delivery from the delivery room also. This has to be definitely emphasized on that. Unnecessary suctioning has taken a back seat. Only if profuse secretions are there, airway is blocked, you are going to suction the mouth. Otherwise, you're not going to do. Then this is the skin to skin contact routinely what is practiced in our hospital, and we have a dedicated nurse from NHM I have kept, because OBG people, they will have other work to do. So our own nurse is posted there for delayed cord clamping. In addition to our postgraduates, she will be monitoring this every day in a clean labor. 2 nurses are posted for 2 labor rooms. So reducing heat loss in less than 32 weeks, use of plastic wraps and thermal mattress and caps. Wrap the baby before even wiping up to the neck with a polyethylene sheet without drying is for preterm babies. And initial assessment, if the answer to this is no, cut the cord, inform the mother. Always you should tell the mother that baby has got some breathing issue. You are going to help the baby breathe. So bring the baby to the resuscitation corner. Position the airways, clear the secretion, first mouth and then the nose, then dry the baby, remove the wet linen, and stimulation is by only rubbing the back. Before we were doing the flicking of the soles or squeezing the rib cage, etc., etc. That is all gone. Now only 3 to 4 rubs, stroking the back is what is ideal. So positioning the airway, it should be in a neutral or sniffing position. That is, need not be fully extended or hyperextended or fully flexed, so that airway, that is pharynx, larynx or trachea in one line. And then you can keep a shoulder roll, that is 1/2 inch to 1 inch, particularly when there is a molding or a huge caput and preterm babies, that will help us. So suction, the M comes first and N comes next. Suction the mouth, at least only turn the baby to the side, and then 5 centimeters in the mouth and 1 to 2 centimeters in the nose. How do you assess the newborn's response to initial steps? So baby starts breathing, then is the baby crying or breathing? Once the baby is spontaneously breathing, then you will have to assess whether baby is adequately breathing. That is, what is the rate? Is the chest moving symmetrically equal? And is there any grunt? If the answer to this is no, this baby goes for observation care. Sorry. Then you have to assess the heart rate. Auscultate the heart rate. Best is to auscultate with the stethoscope on the left side of the chest. Count for 6 seconds and multiply it by 10. Suppose it is at 6 seconds, it is 12. The heart rate is 120, and you have to tell it loud. Inform the rate to the team members so that other team members also will listen to that. And heart rate remains the most important vital steps and most sensitive indicator for your resuscitation. Then if baby is apnea or gasping, so my colleague Dr. Chandrakala would be talking about the positive pressure ventilation. After initial steps, effective initial steps, if baby is not breathing, it goes to the next action. Suppose baby has persistent cyanosis, you can see in this picture, the legs, everything is blue. You will attach a pulse oximeter probe and look at the target saturations and supplemental oxygen, either free flow oxygen or a flow inflating bag, and consider CPAP at this time. So preductal target saturation, you should have a ready reckoner like this, 1 minute 60 to 65. Easy to remember is 65, 75, 85, 95. That is at 1, 3, 5 and 10 minutes. Okay, so better to keep this target saturation table next to the warmer. So administration of oxygen when SpO2, this I have told already, that is room air resuscitation for all babies above 35 and less than 35 depending on the target saturations 21 to 30%. And how to give supplemental oxygen? Through an oxygen tube or a flow inflating bag, what the anesthetist bags are used, and T-piece resuscitator can be used, and tail of a self-inflating bag. This is not much advised. And oxygen flow and concentration, you need a blender. Ideally, there should be a blender with air and oxygen source, and you can titrate from 21 to 100%. Start with a FiO2 of 30. Then titrate depending on the targeted saturation. So how this, I think my friend is dealing with this. I don't want to talk. And in your preparation, you have to check the functions of the bag is important before delivery, not when the baby requires a positive pressure ventilation. This is giving free flow oxygen to our twin babies. And this is again a free flow oxygen through a T-piece resuscitator. So if there is meconium stain, there is no much change. Vigorous, non-vigorous, it is the same approach. Routine intubation and tracheal suctioning is not suggested. You can go for a positive pressure ventilation. So this is all about the algorithm of a first golden minute. Till initial steps I have covered, and next I think will be taken over by my friend. Thank you so much. And this is our 5.9 kilo baby who is on the right side. And these are the twins. Thank you so much.
Thank you, madam. Thank you for your continuous, tireless effort in making us understand. Thank you, madam. You're going to show the demo, madam, now?
Yeah. So we'll be doing the demo of preparation at birth and initial steps, routine care and initial steps. Okay. So thank you, Prashant.
Madam, madam. I will just mute your audio now.
Okay. Okay.
And they can unmute that Vanivila's name is there, no, madam, that mobile device. That one they can unmute. I'm kindly unmute.
Okay.
I want all other devices to be muted except the one. Stop presentation. Stop sharing the presentation, madam. I hope all of them are seeing the screen of Vanivila's hospital name mobile device. Kindly unmute.
No.
Rest all device, keep it in mute mode. Yeah. And you can switch on the camera. Video. Yes, we can see now. Vanivila's video, audio, you can unmute.
Yes, sir. Sir, we'll just take 2 minutes for time.
Okay. Audio needs to be muted. Jyoti K. Okay. Jalaja Lakshmi, mute. Yeah, meanwhile, yeah. Yes. Okay. Yeah. See, the face is not seen. Madam's face is not seen. Can you come little backwards? Little back. Yeah. Try to keep madam's thing on the center of the screen. Move little on the left side. Tilt your mobile on the left side. Yeah. Don't shake the mobile, keep it steady. And when you're focusing on the mannequin, keep it steady. Okay. Yes, madam, you can go ahead.
Okay. So I'll be giving you a history. So there is a 39-week, the mother is about 26 years, who has come in active labor, 39 weeks. Okay, she's in labor. So a call is being given from the labor room. So first of all, I will ask my obstetric provider. So what is the gestational age? 39 weeks. 39 weeks. Okay. Is it a singleton? Single. Is the amniotic fluid clear? Clear, progressing well. Okay, progressing well. And are there any additional factors? No other comorbidities. No other comorbidities. Okay. So I have come to the labor room. I have switched on the warmer. So with 100% heater output in a manual mode. So first is environment check, personal check, and the equipment check. Before that, I will do a hand washing as we spoke about universal precautions. So the hand hygiene. So Dr. Megha will be my other personnel who will be here. So you'll be assisting.
Try to go back and try to show their face properly. You're cutting their face. And keep it steady. Yeah. It's fine now. It's fine. Keep it that way.
So the fan is switched off, the AC is switched off, the doors and windows are closed, and the room temperature is 26 degrees, which is normal. Okay. So now I'm going to, environment check and personal check. So he will be there, Dr. Megha will be helping me if I need any help. So shall we arrange the equipment? Can you do a quick equipment check? Okay. So from head to foot for warm, what do we need? We need 2 pre-warm towels.
Keep it steady. Don't move the camera. Keep it steady. Yes, keep it steady that way. Don't move. Don't shake the camera.
So for keeping the baby warm, we have a hat or a cap. And then, so for wiping the eyes, we have 2 sterile cotton swabs to wipe the eyes. So shoulder roll 1/2 inch to keep the baby's positioning. Suppose you need if it is a preterm, extra heated chemical heating mattress or a cling wrap is available. So clearing the airway, we have a Delisle mucus sucker. Suction tubes 10 and 12. Stethoscope. This is for auscultation. So for oxygenation, we need a flow meter and a blender. We have a T-piece resuscitator. Ventilation, we have it's a term baby. So I have taken a term bag with a mask. I'm going to check the functions of the bag. So to apply, you cannot apply like this. We hold it like this and clockwise. So check the functions, the 3 functions, whether it is self-inflating, whether it is having adequate pressure, and the pop-off valve is working. So hissing noise is there. So whether pop-off valve is working. So the bag is working with a reservoir. And suppose baby requires positive pressure ventilation, 8 French OGT is kept. And then pulse oximeter. So ET tubes 3.5. So laryngoscope working with 3.5 ET tube and measuring tape to measure the nasotracheal length if required. And scissors for if needing the umbilical cannulation. And drugs, coming back to medications, the adrenaline, the expiry you have to check always. 2022. So it's already pre-filled syringe is loaded, 1 ml and 9 ml of saline for IV. And umbilical catheter, 5 French is ready, and saline. And the name tag. For labeling, you need a name tag. So we are done with the preparation. Baby has been delivered. So I think this is the mother. So baby is delivered onto the mother's abdomen. Time 3 p.m. Okay. It's a term baby. Baby's tone is good. Crying. Baby's breathing. Okay. So baby will stay with the mother and tone is good. And it's a female baby. Suma, your baby, you have a female baby. Congratulations. So baby is nicely, lustily crying. Dry the baby. Remove the wet linen. Don't rub the vernix. It is only gentle rubbing the back. And cover the baby. Put a name tag. So you will look at the time. What's the time? 1 minute.
1 minute.
1 minute.
Yeah. So 1 minute up. So after 1 minute, emphasis on cord clamping, cutting the cord. Okay. Then continue skin to skin. And Suma, your baby is fine. Please start breastfeeding the baby. Okay. So at least for 1 hour, we are going to keep the baby skin to skin. And here emphasis in routine care is keeping the baby warm. Then delayed cord clamping, then breastfeeding. Okay. So one more scenario. So one more scenario you can give. She is an obstetric provider. She will be giving a scenario. Yeah, you can give.
A 30-year-old mother, gestation age of 42 weeks, life is meconium stain, and comorbidities is PIH, pregnancy induced hypertension, and also fingerprint pregnancy.
Okay, thank you for calling. So breathe. So all the things are kept ready. So Dr. Supriya, can you help us? Yeah. So you take care of the positive pressure ventilation. So you will be documenting the Pranati. You will be documenting the events. Okay. So and Megha, you will be we will be documenting the events. Okay. So and preparation is ready. Warmer is on. Warmer is switched on. So the room temperature is normal. So equipment check has been done. A quick assessment. So baby. So this is a little complicated. There are additional risk factors with the mother PIH and meconium stained liquor. So I'm going to be little cautious with this. So babies. Record on the other type of baby. So, yeah, the baby don't the baby don't not baby. Okay. So the baby has some problem. So I that come back to the form. Right?
Yeah, we can't see.
Who the vegetable?
No, we can't even on.
So baby has started breathing. Okay. And check the heart rate. See? So heart rate is 100. So baby started spontaneous breathing. So this baby will go to observation care with the mother. So I'll put a cap. Put the name tag and go back to the mother. Okay. So Anita, your baby is fine. He had some problem in breathing. Please start feeding the baby. Meanwhile, if there is any issues in feeding, breathing and temperature, I'm going to come back here. So every 15 minutes, we have to check the baby for at least an hour on the mother's side. He needed, with this has to be done within 20 to 30 seconds. So these is initial steps. Thank you. Prashant? Prashant?
Yes, madam. Yes, madam.
Madam,
So initial steps. After initial,
Prashant, go ahead.
yeah, if the baby is not breathing, baby requires a positive pressure ventilation, and my friend will be continuing this. Okay? Prashant, can you hear?
Yes, madam. Yes, madam.
Yeah. Thank you so much.
Thank you. Thank you. Thank you, madam. Thank you, madam, for your wonderful presentation.
Now we can speak.
So, Dinakar sir.
Yeah, Prashant, we will take
Yes,
up the questions not now, because there are 9 questions have popped up for Dr. Sahana madam. We will ask Dr. Sahana later. Now we will go to the 2020 NRP updated things from Dr. Janaki madam. Before that, I really thank Dr. Sahana. She has exactly taken 1 hour 5 minutes. She has given 10 minutes to us. Thank you, madam. Thank you. And now over to Dr. Janaki. Dr. Prashant.
sir. Yes, sir. Yes, sir.
Yeah, you have
Thank you,
already.
Dr. Dinakar.
Yeah, please. Prashant, introduce Dr. Janaki madam quickly and let her take over.
Yeah, I've introduced madam already, and she doesn't need any introduction at all. because Madam has been a master in Neonatal Resuscitation Program with more than 15 years plus experience. Madam, correct me if I'm wrong, 15 or 18 years. So she's one of the pioneer in Karnataka state to start this NRP program. Madam, over to you. Over to you, Madam.
Yeah. Thanks a lot, Prashant. Thank you for those very kind words. Are you able to hear me, Prashant?
Prashant, mute everybody except Dr. Janaki, madam. Mute everybody.
Anviti, can you mute all?
Yes, sir.
Mute.
Janaki, Madam, you unmute yourself, Madam. Madam, unmute yourself, Madam.
So can you see the slide, sir?
Yes, I can see the slides.
Are you able to hear me, Prashant?
Yes, Madam. Go ahead, Madam.
Yes. A very good evening. Thanks to Prashant, Dinakar, and the entire NNF team for giving me a chance to be here today. The next 10 to 15 minutes, we shall concentrate on what is new in NRP. What are the local recommendations done for the year 2020? These recommendations are done by the International Committee of Resuscitation, the Liaison Committee of Resuscitation, and the AHA. They met in early 2020 and these recommendations have been made. So there are about 10 to 11 recommendations made. Of these, there is no real landmark change that has happened, but what they have done is they have laid more stress and emphasis on certain clinical interventions. For example, certain clinical activities which are very, very impactful in clinical practice have been given more importance. And what is very important is these recommendations have been based on randomized trial controls, systematic reviews, and meta-analysis. What is very impressive is a number of papers have turned out in the last 3 to 4 years, and a lot of these recommendations are based on this research. So let me just outline these recommendations. This is the classical NRP algorithm that is there. There is absolutely no change in the algorithm. The algorithm remains the same. So there are about 10 to 11 considerations that have happened. And the most important thing is preparation for birth, which Dr. Sahana has already spoken to us about. What I would like to emphasize is before the delivery of every baby, we all check the equipment, etc. But what is lacking in our setup is two things. One is anticipation of the need for resuscitation. And second thing is forming a team. These two things are pathetically lacking. And these preparations have to be done in order to have good results. Please remember the old adage, being prepared is half the battle won. And failing to prepare is like preparing to fail. So what are the things we prepare? Equipments, personnel, and very, very important is delegation of responsibility of people. All of us have been following the rule that at least there is one person for every delivery. But in spite of this, 50% of our asphyxias are totally unexpected. All of us know that 20% of our neonatal deaths is due to perinatal asphyxia. And of these perinatal asphyxia babies, about 50% come as a very, very rude shock in the delivery room. Is there any way that we can prevent this? The obstetrician says, oh, everything was hunky-dory, but then we got a flat baby, a baby with very, very poor Apgar scores. So is there any way in which we can anticipate problems in certain pregnancies? So research has shown that there is what is called a risk stratification that should be done before every delivery. In our labor room, we have these risk factors put up, and if this risk factor list has been met, then the resuscitation team is formed, at least 2 to 3 people, a thorough equipment check. And the most important is team briefing. What do I mean by team briefing? That means allocation of responsibilities to individuals so that each one knows what exactly he should be doing. There was a very interesting randomized controlled trial that was done where they looked at two teams. One team where no briefing was done prior to delivery, and the other team where team briefing was done. It was conclusively proved that confusion and chaos was almost absent in the team that had briefing prior to delivery. So this must be really emphasized. We must anticipate asphyxia. We must have a risk stratification score. So what exactly is this risk stratification score? Berazatua et al. In the Archives of Disease of Child in 2017 have put up a very nice article where they've done an extensive study and identified the following risk factors as predictive of severe perinatal asphyxia. Of course, premature babies, IUGR, maternal emergencies in the form of abruptio placenta, chorioamnionitis, and any fetus with a fetal bradycardia or the type 2 dips on the CTG, and instrumental deliveries and maternal morbidities like gestational diabetes and PIH, a mother who has been given a heavy dose of anticonvulsants, sedations, and meconium-stained amniotic fluid. So if these risk factors are there, it should alert the resuscitation team to be very, very careful and be more cautious about preparing themselves. So now let's begin with the good news. After we have prepared ourselves, we've had a team formed, we have checked our equipment. Most important, we have delegated responsibilities. Let's start with the good news. We have a term baby who comes out screaming and crying. The ILCOR and the AHA have not only given recommendations for sick babies or depressed babies, but there are also very clear-cut recommendations for term babies. So what are the two clear recommendations for term babies? Number one is skin-to-skin contact. We all know that the temperature of newborn has a lot of impact on mortality. You'll be surprised to know that for every degree fall in the body temperature of a neonate, the mortality, the first 7-day mortality, is shockingly increased by 28%. So the ideal temperature at which we should be maintaining newborns is between 36.5 to 37 degrees. And what is the best way to do it? In a term baby who's come out well, the best way to maintain temperature would be skin-to-skin contact with the mothers. All postgraduates, please note, there is absolutely no role of warmers. Warmers are a strict no-no as far as term neonates are concerned. Warmers are used only for premature babies, low birth weight babies, and babies who require resuscitation. So what proof do we have of this? There have been 6 randomized controlled trials that have demonstrated that a well neonate who is given skin-to-skin contact for about 1 hour after birth, there are 3 great advantages. One is breastfeeding rates are much better in these babies. There is improved weight gain and reduction in the hospital stay. So after these 6 RCTs, there has been a firm assertion on the role of skin-to-skin contact, and there is strictly no role of warmer care in a term baby who is delivered in a good shape. But what about our premature babies? Premature babies, of course, have a lot of their own disadvantages. So in a baby less than 30 weeks or an extremely low birth weight baby, a baby who is depressed, who may need a lot more thermal support compared to a plain skin-to-skin contact. So in such babies, we definitely shift them to a warmer and we give them extra thermal support in the form of mattresses, polythene wraps or cling wraps. And what is very important is even in resource limited setting, let's say there is a delivery of a low birth weight baby or a premature baby in a peripheral center. So they do not have, in our country, we do not have transport incubators to shift these babies. So how can they be shifted? They can be definitely shifted with a sterile polyethylene bag, which can maintain temperature and prevent transepidermal water losses. So this is the first recommendation that has been given a lot of assertion in a term baby. The second one is, of course, as already mentioned by Dr. Sahana, delayed cord clamping is the way to go. So what is the evidence here? Evidence has been published in the American Journal of Obstetrics and Gynecology in January 2018. So this was a very amazing study where they had 18 RCTs which enrolled 2,834 babies. And there were very clear advantages of delayed cord clamping. Cord clamping is advocated to be done about a minute after birth in a well baby. So what are the advantages in a term baby? They have better hematocrit, better blood pressure, ferritin levels. They also found that the cognitive outcomes in these babies are better. So how are cognitive outcomes better? All of us know that iron is a very, very important element for CNS action. So by increasing ferritin levels, we are improving the cognitive outcome of these babies. Please remember, I want to stress one thing. As the baby is transitioning into his extrauterine life, the first couple of minutes, if you clamp the cord immediately after birth, the entire lot of blood remains in the placenta and the baby is deprived of something like 70 to 80 ml of blood. So during early transition, please do not clamp the cord. Let him have the advantage of this 70 to 80 ml of blood. That will give him a better hematocrit, better ferritin levels. And as far as my premature babies are concerned, very, very important. We have found that premature babies who have had delayed cord clamping have reduced need for blood transfusions in the NICU. They have reduced need for inotropic support. So once you have reduced need for inotropic support, their outcomes are better in the sense their risk of IVH, etc. is much lower. So both for term babies as well as premature babies who come out well, perhaps premature babies above 30, 32 weeks, definitely delayed cord clamping is the way to go. But I must mention here that delayed cord clamping is not advocated for all babies. There are certain indications when we should be doing what is called ECC, that is the early cord clamping. For example, if the mother herself is unstable, she's had an antepartum hemorrhage because of placenta previa or abruptio placenta. Or if there has been an IUGR baby who's had abnormal Doppler flows, placental insufficiency, things like that. Unstable baby, unstable mother, early cord clamping is the way to go. There was another major RCT, a large RCT, that looked at this practice of cord milking in premature babies. The results were very bad. They found that major IVH, grade 3 to grade 4 IVH, was more common in babies who had had cord milking. So at the moment, the LCOR has not recommended cord milking in these babies. Perhaps it can be done only on a research setting, but not done as a routine practice. Next, we come to babies who are depressed. The two important things we look at when babies are delivered is the baby crying and is the baby breathing. So when we have a depressed flat baby who's not breathing, who's not crying, Sahana has very nicely explained to you what procedures have to be done in these babies. What the AHA and the ILCOR, they've made a slight change in the setting, slight change in the way in which we do things. They say even in depressed babies, suctioning can be avoided and we can perhaps stimulate these babies by tactile stimulation. Please try rubbing the back 2 or 3 times. And if the baby starts breathing, you have avoided suctioning. Because suctioning is really a noxious procedure that can result in bradycardia and can result in apnea. So even in the setting of a depressed baby, please try stimulation first. And if stimulation does not work, if there is visible fluid in the oral cavity or if there is an obstructed airway, only then there is an indication for suction. And of course, this landmark judgment that was done in the 2015 NRP, that is management of a MSA of meconium stained depressed baby, no ET suction definitely stays. We definitely do not have to do an endotracheal section. Instead of doing an endotracheal suction, please start positive pressure ventilation. This change has come about mainly because we do not want to waste 20-30 seconds of the first golden minute. Instead, we would much rather oxygenate the brain. The primary focus should be to get oxygen into the brain within the first golden minute. We can definitely deal with meconium in the lungs, but we should not deprive a baby's brain of oxygen, which can result in long-term consequences. So what is the support for this? Very nice article in Resuscitation 2020. I've written the references down. Because of time constraints, I'm not able to show you the results of these articles. Prashant has told me very strictly that I should back off in 15 minutes. So I shall put up all the references at the bottom of my slide. So there were 3 RCTs, which is very interesting, that looked at 2 groups of babies. One group of babies who had ET suction, the meconium stain depressed babies who underwent ET suction. The second group that did not have ET suction. So it is very, very pleasant surprise that they found that there was no difference in the survival between these 2 groups. There is no difference in the respiratory support or the ventilatory support that they looked at. And very heartening is there was no difference in the neurodevelopmental outcome. So through these excellent RTCs, the ILCOR and the AHA have re-emphasized that we should not be suctioning meconium stain depressed babies. Instead, we should concentrate on oxygenating their brain by doing a positive pressure ventilation. Next, we come to the most critical step of neonatal resuscitation, and that is positive pressure ventilation. Please note that initial steps of resuscitation takes about first 30 seconds, and at the end of 30 seconds, if the baby is apneic, or if his started saturations are not met, or he is bradycardic and gasping, we start positive pressure ventilation. Starting positive pressure ventilation at this correct time is very, very crucial, because research has shown that delaying positive pressure ventilation by 30 seconds increases mortality by 16%. This is pretty shocking. So it is very good that we all get our act together, check all our equipment, keep everything ready, start PPV as soon as possible, as soon as it is indicated. The current focus on positive pressure ventilation is it would be very good to introduce PEEP, or the positive end expiratory pressure, in addition to PIP. Traditionally, we have been giving only PIP, but it would be very good, especially in premature babies, to introduce EEP, that is the positive end expiratory pressure. This introduction of positive end expiratory pressure has a lot of advantages, especially in our preterm babies. It improves the FRC, keeps the alveoli open. It reduces the ventilation perfusion mismatch, and most important, conserves surfactant. So how do we introduce PEEP into our bags? Number one, you have seen this traditional ambu bag. It can have an optional attachment of a EEP valve. We have it in our unit. In fact, this EEP valve can be given as an attachment to the traditional ambu bag, or we can use flow inflating bags that the anesthesiologists use. The third option is that we go for a T-piece. Going for a T-piece ventilation is very, very ideal, because with a T-piece ventilation, we avoid high tidal volumes. That means the pressures are uniform in every breath. So high tidal volumes are avoided, air leaks are avoided, and we have better outcomes. So introduction of EEP is something that is emphasized in the current NRP. And of course, how do we assess the effectiveness of our positive pressure ventilation? It is mainly by a rise in the heart rate. If you have a rise in the heart rate, that means you're doing a good job, continue. But one more golden rule is that as soon as you start positive pressure ventilation, you must have a pulse oximeter, because you should know what your oxygen saturations are. Pulse oximetry and ECG monitors are 2 additive equipments that we use for monitoring oxygenation. When do we use an ECG monitor? ECG monitors are not routinely used, but any baby requiring chest compression and medications, or any baby requiring prolonged resuscitation where you're having a really hard time getting this baby around, ECG monitors have been definitely recommended. This is because a pulse oximeter may not pick up the signals at all in the initial phases. So when the pulse oximeter does not pick up the signal, you presume that the baby is bradycardic, and you go ahead with chest compression, medication, do a lot of unnecessary procedures. Whereas an ECG monitor is very, very sensitive in picking up the heart rate. And so these aggressive forms of resuscitation may be avoided if you have better information about the heart rate. There were a group of very enthusiastic neonatologists who looked at what is called sustained lung inflation. That means you hold the baby inflated, his lung inflated for about 15 to 20 seconds. They found that this was associated with a higher mortality. So sustained lung inflation is no longer recommended. But the use of pulse oximeter and ECG monitor in difficult resuscitation have been emphasized. But please note that even if you do use an ECG monitor, you cannot do away with a pulse oximeter, because pulse oximeter is the one that is telling you about the oxygenation status. ECG monitor will tell you about the heart rate. So it would be good to use both of them concurrently when we have a difficult resuscitation. Now, all of us know that we start resuscitation in term babies and late preterm babies with just room air. And in premature babies who are less than 35 weeks, we may use FiO2 between 0.21 to 0.3. Studies have conclusively proved that 100% oxygen is associated with much higher mortality. Again, I would like to quote a landmark study which was done by our own Professor Ramji and Ola Saudstad, wherein they found that with room air resuscitation, there was no difference in the death rate or in HI, degrees of HI. So the way to go is please start with room air. And depending on your target saturations, please dial up the oxygen. The picture that you see is that of an oxygen blender. So it's very important that we use blenders, especially in preterm resuscitations, which we will be showing you later on. So when we use a blender, we avoid 100% oxygen. So free radical damage to the eyes, to the kidneys and the brain are avoided. So the emphasis is definitely to start with room air in term and late preterm. Even in preterms, we do not start with 100% oxygen. We start with perhaps 25 to 30% oxygen. Coming to chest compressions, the two-finger technique is totally given up. It's only the two-thumb technique that is preferred. And the ratio between chest compression to ventilation will be about 3:1. Now, why did they recommend this two-thumb technique? This is because of very good research that has been done on animals. They found that if we did the two-thumb technique, there were better systolic blood pressures and mean pressures, and more importantly, the coronary perfusion was much better when we did the two-thumb technique. And personally speaking, we have also found that with the two-thumb technique, the operator fatigue is much less compared to the two-finger technique. So the two-thumb technique and 3:1, that is very, very important. There's just another thing that I would like to emphasize in bag and mask ventilation. In bag and mask ventilation, please remember that we have to use this mantra of breathe 2, 3. Breathe 2, 3. Only when we use this mantra, we are ventilating at rates of 40 to 60. If we do not call out these numbers, we end up hyperventilating the baby. So when you hyperventilate the baby, you lose out on CO2, which can cause a lot of damage to his brain. So avoiding hyperventilation and avoiding high tidal volumes with the use of a T-piece resuscitator. These two recommendations are important. We finished chest compressions. Next, we come to medications. So when do you administer medications? You administer medications when you have had effective positive pressure ventilation for 30 seconds and positive pressure ventilation combined with chest compressions for 60 seconds, and you still have a low heart rate. This is the time you go into medications. And of course, when you have to do medications, it's always the umbilical venous route that is preferred and not the intraosseous. And the drug of choice, of course, is 1 in 10,000 adrenaline. It's been proven that IV adrenaline is much, much superior to the endotracheal route. So IV adrenaline is the way to go. Flush the UVC with IV adrenaline followed by saline. And they've also been very particular about when normal saline is to be given. Normal saline is to be given only when you have historical data. That means you have a data that mother has had an antepartum hemorrhage, or clinically you find a baby who's really shocked and pale and who's not responding to IV adrenaline. Only then you go for a normal saline push of 10 mils per kilo. So despite all this, in the unfortunate event that you are not able to resuscitate the baby, when is the time to stop? The latest recommendation is if you do not hear heart rate after 20 minutes of effective resuscitation. Please remember here, the most important phrase is effective resuscitation. If after effective resuscitation, you are having a 0 heart rate confirmed clinically as well as with ECG, First, what you need to do is the team should discuss amongst themselves whether anything else can be done for this baby. But once the team members agree that they have done their best and unfortunately the baby has not responded, then the parents are informed. Of course, it's a lot of shock for the parents. We continue to resuscitate till the parents, the parents are able to accept that nothing is possible for this baby. Then only resuscitation is stopped and the baby is given what is called redirection of care. That means compassionate care. The mother just holds the baby in her lap and we give the parents time with the baby. So this recommendation again is based on this article in Circulation 2020. So just to summarize, I shall just give 10 take-home messages from the latest NRP 2020. Most important, please be prepared. Please be prepared for a resuscitation in terms of personnel, in terms of equipment. Number 2, for a term baby, please follow skin-to-skin contact. Do not keep them under warmers. Delayed cord clamping. Clamp the cord only 60 seconds after birth. And when avoid unnecessary suction during initial stimulation, during the initial actions or the initial steps. And when you do positive pressure ventilation, please use the positive end expiratory pressure to keep the lungs open and to establish FRC. Of course, a rising heart rate is the most important indicator that you're doing a good job. Pulse oximeter is a must whenever we start positive pressure ventilation or whenever oxygen is being used in neonatal resuscitation. Pulse ox must be hooked on. ECG must be added on when we come to the stage of chest compression, medications, and any prolonged resuscitation. IV adrenaline preferred to ET adrenaline and normal saline 10 mils per kilo if there is evidence of hypovolemia. So stop resuscitation if no heart rate 20 minutes after effective efforts. And then we go for what is called redirection of care. Thank you very much for a patient hearing.
Thank you ma'am, for your presentation of 2020. We will we'll move on to the next topic. So I request Chandrakala madam to start. Thank you, madam. Thank you, Janaki madam.
Thank you, Prashant. Thanks for the opportunity.
See you again after Chandrakala madam's talk. Thank you.
Yeah, sure. I'll see you again.
Yeah.
Slideshow. Yeah. Dr. Prashant, can you see the slide?
Yes.
Done. First, good evening, everyone. I would like to thank NNF team, Dr. Dinakar, Dr. Prashant, Dr. Koturesh for giving this excellent opportunity. Of course, this is my passion. Thanks everyone for giving this opportunity. So straight away I'll go for my topic of presentation today, positive pressure ventilation. We have discussed in the previous session by Dr. Sahana that what is the indication for positive pressure ventilation. So this flow you all have seen already. So directly we'll go for the indications. So this is where, so even after 30 seconds of initial steps of resuscitation, when the baby has, you will look for the heart rate and respiration both. When the baby has apnea or gasping or the heart rate below 100 centimeters is an indication for positive pressure ventilation. So also there is one more indication. I don't know whether it was discussed there. So I'll just go to the flow chart here. So when after 30 seconds of initial steps of resuscitation, when you look for heart rate and
Madam, kindly unmute, madam. Unmute yourself, madam. Unmute the audio. Prashant Vayan, your device audio unmute. Yeah, we can hear.
Can you hear me?
Yes, madam. Yes, madam. Go to the presentation.
So you did not hear any of what I presented now?
We heard you, madam. Only for a few seconds it got muted. That's all.
Okay, let us go for the indication for positive pressure ventilation. So here, after 30 seconds of initial steps of resuscitation, when we assess the heart rate and respiration of a baby had heart rate of more than 100 and the baby had breathing. And this, I'm talking about this diamond, when the baby had persistent central cyanosis. So when the baby had persistent central cyanosis, you started giving oxygen to the baby. So even after giving 100% free flow oxygen, baby continued to be having central cyanosis or the saturation not in the target of for his age. So that is also one of the indication for positive pressure ventilation. So we have three indications for positive pressure ventilation. That is, if the baby has apnea or gasping, or the heart rate of less than 100 per minute, the oxygen saturation below the target range despite free flow oxygen, or CPAP, is an indication for positive pressure ventilation. So now, what are the equipments needed for positive pressure ventilation? So we need face mask for term and a preterm baby. That we will demonstrate in the next session after my theory. Self-inflating bag or with the oxygen tubing, with a reservoir, or you can have flow inflating bag, which otherwise called as anesthesia bag, or what is recommended is TP's resuscitator with tubings. And you need to, when you are resuscitating a preterm baby, it is very important to have pulse oximeter with a neonatal probe. And of course, Dr. Sahana has already mentioned that you should have an oxygen saturation target table in the labor room. And if you have to give positive pressure ventilation for a long time, then you need to have an infant feeding tube, which is 8 French and 20 cc syringe to vent the stomach, and of course stethoscope to look for the air entry. So these are the different types of resuscitation, the positive pressure equipments you can use. This is what we commonly use is self-inflating bag. As the name implies, even though it is not connected to the oxygen, or even though there is no airtight seal between the face and the mask, this bag is inflated all the time. After being squeezed, it draws air and oxygen from the environment and again it is inflated. That is why it is called a self-inflating bag. So this is flow inflating bag and this is TP's resuscitator. This TP's resuscitator is very important to have for preterm resuscitation. But drawback of these two are that these two need, for the functioning, we need to connect it to the oxygen source. So this I can demonstrate that the parts of the bag in the demonstration session in the next after 10-15 minutes. And this is this I'll demonstrate later. And this is the reservoir, the two types of reservoir. This is the open-ended corrugated one and this is the closed reservoir. You can use either of the two. What is recommended that all of us know that in the 2020 recommendation and even earlier also, TPS resuscitator is ideal for resuscitation of preterm baby. Why is it so? The advantages are, it gives consistent pressure and which is not possible to do in self-inflating bag, and reliable control of PIP you can control with that, PEEP you can control, FiO2 you can control if you connect this TP's resuscitator to the blender. If you do not connect this to the blender, you will be giving reliable delivery of 100% oxygen. And more importantly, operator does not get fatigued from bagging. Very important. But same time, we also have certain disadvantages. This requires gas supply but the compliance of the lung cannot be felt. And this you need to set it up before you use. So 2020 recommendation Dr. Janaki has already set. Next important one when you are giving positive pressure ventilation is selecting an appropriate mask. Two types of face mask is available. This is a triangular one and this is the cushion round face mask. So the correct face mask for that particular baby is one which covers the tip of the nose, mouth and the tip of the chin. So here I have given some examples of the correct ones and the incorrect ones. This is a triangular mask which covers the nose, mouth and the tip of the chin, and this is a rounded mask, cushion mask. This is correct, and here you will see here the one which is small and this is big and this is not correct. So choosing appropriate size mask is very, very important. Now, how do you place it on the baby? So placing on the baby's face is also very important. Start from the chin and cup it to cover the nose and the mouth. What is important is to have airtight seal between the rim of the mask and the face. This is very important requirement. So, and you hold the mask with your thumb and the index finger and rest of your three fingers on the jaw of the baby, angle of the jaw. You lift up the jaw and press the mask gently on the face to have airtight seal, which I'll be demonstrating little later. So when the baby requires positive pressure ventilation, how much of oxygen you should be using, that we have already discussed. Any baby more than 35 weeks of gestation or equal to 35 weeks of gestation, when it requires positive pressure ventilation, you should be using room air resuscitation or 21% oxygen. If the baby is less than 35 weeks of gestation, anywhere you can use 21 to 30%. How do you know 21 to 30%? Only when you use the blender. When you use a blender, you can set the amount of oxygen you can give it to the baby. And based on the saturation target for the age, you can set 25 and 30. So this I have discussed already, and the 2020 recommendation already has been discussed. So now we know that when we are giving positive pressure ventilation, we have to look at the chest of the baby. We cannot be looking at the clock to know whether I'm giving the correct rate of positive pressure ventilation. All of us know the normal rate of breathing is 40 to 60 per minute. So even when you are giving positive pressure ventilation, you should be giving at a rate of 40 to 60 per minute. So when I'm concentrating on the chest of the baby, because when I give correct positive pressure ventilation, there is chest rise. Hence, I need to look at the chest rise and not at the clock. So then how do I know that I'm giving it 40 to 60 per minute? So you need to follow mantra. This is what Dr. Janaki was saying, a rhythm. Okay, what is that rhythm? Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. For that, you need to have 40 to 60. You need to practice this earlier. Right? When I say breathe, you need to squeeze. 2, 3, you need to release. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Right? This is very important to have a correct rate of ventilation. Now, how much I know the rate, and I've positioned myself at the head end of the baby. Now, how much pressure I need to give? Unless you have TP's resuscitator where you have set the required PIP, you will not be knowing how much of pressure I am giving unless you connect a pressure manometer to the self-inflating bag. You will not know. So how much pressure? So if you do not have a pressure manometer attached to your self-inflating bag, you need to give a pressure which causes just gentle rise of the chest of the baby. Right? So to be more objective, you need to start with 20 to 25 centimeters of water And for the term baby, you can anyway start from 30 to 35, and gradually, if there is no chest raise, gradually increase or increment by 5 centimeters of water. So this is the pressure. Then, how do you know that you are giving positive pressure ventilation effectively? What is the response you are going to see? So, when you have increase in the heart rate, that says that you are giving effective ventilation. My positive pressure ventilation is good. So how do I know that my positive pressure ventilation is effective? You will see gradual increase in the heart rate. That is very rapid. Now, I start giving positive pressure ventilation. What should I do? I should call for help. I should call for help for what? I need to have two people. For me, that person will attach a pulse oximeter to the right hand. Why right hand? This is pre-ductal saturation. The moment you start positive pressure ventilation, simultaneously you call for help, attach a pulse oximeter to the right hand. So I start giving, after attaching a pulse oximeter to the right hand, I start giving positive pressure ventilation at a rate of 40 to 60 per minute. How do I give? Breathe 2, 3, breathe 2, 3. So in approximately 15 seconds, in 15 seconds or approximately 10 breaths, okay, so you ask your helper to watch out on 15 seconds. After 15 seconds, I started positive pressure ventilation. I will look at the pulse oximeter to see whether the heart rate is rising in my pulse oximeter. There are three scenarios here. I want to check the effectivity of my positive pressure ventilation. That is why I want to check after 15 seconds of I start positive pressure ventilation. So that is approximately 10 breaths. In 15 seconds, when I check for the increase in the heart rate, yes, three things can happen, three scenarios can happen. In the first scenario, yes, the heart rate is increasing. When the heart rate is increasing, what I think is, yes, my ventilation is effective. Let me continue for 15 more seconds. That comes to 30 seconds of total positive pressure ventilation. And at the end of total 30 seconds of positive pressure ventilation, I check the heart rate of the baby. Okay. So the heart rate after total 30 seconds of positive pressure ventilation, if the heart rate is more than 100 and the baby has spontaneous breathing, gradually I taper and stop. Right? The second scenario can happen when I check the positive pressure, the heart rate after 15 seconds of positive pressure ventilation. The first one I said the heart rate started increasing. The second scenario, the heart rate is not increasing in the pulse oximeter. So when the heart rate is not increasing the pulse oximeter, then I ask my assistant to look at the chest rise or auscultate the chest for air entry. Either you can do any one of that, not both, based on your comfort. If the chest is rising or there is air entry when you auscultate it, that means I am giving effective positive pressure ventilation. Even in that scenario, you can continue positive pressure ventilation for next 15 seconds. Then that becomes total of 30 seconds of positive pressure ventilation. Then I check the heart rate of the baby. Then of course you take the action based on the heart rate of the baby. The third scenario can happen that I'm not able to see increase in the heart rate in the pulse oximeter. Then I ask my assistant to look at the chest rise or auscultate for air entry. When my assistant says there is no air entry by auscultation or there is no chest rise, you need not have to check both air entry and chest rise. Any one, either of the one should be fine. So there is no air entry, there is no chest rise, and the heart rate is not increasing. That is the indication to say that I need to take ventilation corrective steps. My ventilation is not right, not effective. This is clear. So when I start giving positive pressure ventilation, in 2 times I check the heart rate of the baby. In between, in 15 seconds, I check the heart rate, whether it is increasing or not. Based on that, I take decision whether I need to continue or I need to give ventilation corrective steps. Now, what are the ventilation corrective steps I'm going to take? So it is very easy. It is MRSOPA, Mr. SOPA, right? So I do this MR. M is mask adjustment on the face and reposition the airway, reposition the neck of the baby. So airway. So MR. I do both of these things and then I will again start giving 5 breath to the baby. MR I do, and I will give 5 more bit to the baby to know whether the ventilation is effective, whether there is chest rise. Now, there is no chest rise. Then I will take the next 2 corrective steps. That is, I'll remove the mask. I do suctioning of the mouth and the nose, and I open the mouth little and again place the mask correctly. Then I will start giving 5 more breath to the baby. Breathe 2, 3, breathe 2, 3. After giving 5 breath to the baby, again I will look at the chest rise to see, is my ventilation effective? Yes. Still there is no chest rise. If even after MR, even after SO, there is no chest rise. That means still my ventilation is not effective. Then I will go to the next step, that is to increase the pressure. I increase the pressure, I'll press little hard, or if you're using your TP's resuscitator, I'll increase by 5 and again give breath to the baby. Breathe 2, 3, breathe 2, 3, 5 more breath to see whether I get chest rise. If still I don't get chest rise after MRSOP, then I will go to the alternative airway, that is nothing but endotracheal intubation. If I get chest rise after any of these steps, you need not have to go to the next step of corrective measures. You can continue from that time for 30 seconds positive pressure ventilation. Clear? Okay. So if I get chest rise after MR, then that means that is the time I count from. Then I will give 30 seconds of positive pressure ventilation. Remember, this is from the time of chest rise. Right? So now, how long I need to give the positive pressure ventilation effectively? I give effective positive pressure ventilation for 30 seconds and then I will look at the heart rate of the baby. There are 3 things can happen. When I looked at the heart rate of the baby, heart rate is more than 100 beats per minute. Then that is a time for me to also look for respiration. If the baby has a spontaneous breathing and the heart rate more than 100 beat per minute, that is an indication for gradually tapering the breath, positive pressure breath, and gradually taper and then stop ventilation and look at the saturation and even remove the oxygen. Another thing can happen. The heart rate is less than 60 beat per minute. After 30 seconds of effective positive pressure ventilation, when I check the heart rate of the baby, it is less than 60 beats per minute. That is an indication that I should move on to the next step of resuscitation, that is chest compression. Right? But there are third thing can happen. When I check the heart rate after 30 seconds of effective positive pressure ventilation, the heart rate is more than 60, but it is less than 100 beat per minute. Then you continue positive pressure ventilation. If still the heart rate is not improving, see whether you need to intubate the baby. Very important. It is not an indication for chest compression and it is not an indication for stopping positive pressure ventilation. You need to continue ventilation. You may have to intubate the baby at that point. Then, when do you insert orogastric tube? When you have to give a positive pressure ventilation for a long time. As I mentioned now, the heart rate is more than 60, but it is not more than 100. That is a time. So when you, for few minutes, when you give positive pressure ventilation, you need to pass the orogastric tube and you need to vent the stomach. How do you measure to what length I need to insert the orogastric tube? Don't pass nasogastric tube because there is the positive pressure ventilation might become ineffective. Pass orogastric tube, it is easy and it is comfortable. Right? From the bridge of the nose, as it is shown in this picture, from the bridge of the nose to the tragus and then to the point midway between the umbilicus and the xiphoid process. So that is the length you need to insert orogastric. It is very important to do this because when you give positive pressure ventilation for a long time, the air not only goes to the lungs, also goes to the stomach and it makes the ventilation ineffective. Now, so this is what I discussed. The heart rate is less than 60. What do you do? So the next step is chest compression. We will be discussing little later. So we will move on to now the demonstration.
Sir, lot of from Rashmi
Yeah. Mute one device which you are planning to use it for demonstration. Only unmute that. Mute this laptop presentation.
So now let us look at the equipment necessary for.
Just wait, ma'am. So Rashmi has to unmute.
It's unmuted.
You tell me when I should start, then I will. So let us look at the equipments needed for positive pressure ventilation. So as I mentioned already, this is the mask. So in the preparation, I think we did not learn about how to know whether this is functioning. This is one size mask, and this is zero size mask. This is for the preterm. This is one size mask, and this is the preterm mask. This is the preterm mask, 0 and 1 size. Is it seen? Right?
Yeah.
Okay, done. So this is the way to fix the mask.
Camera, keep it
This is the
steady.
way to fix the mask. And this is of the pediatric capacity 250 to 500 ml. This is the self-inflating bag. This is the self-inflating bag. This is air inlet. This is where I connect the reservoir. And this is the oxygen inlet. This is where I connect the oxygen. And this is inlet and this is outlet. Air outlet, this is where I connect the mask. This is the way I connect the mask. Okay. So this is a pop-off valve. And this is the valve assembly. Right? So what is the functions of the pop-off valve? So this pop-off valve is set it at 25 to 30 centimeters of water. If you give more pressure without your knowledge, that extra pressure pops off. So how do I know this self-inflating bag is functioning? There are 3 ways to know that this self-inflating bag is functioning. 1, when I press, it goes back to its original position. 1. 2, I can feel the pressure of when I'm giving the pressure ventilation. The third one is if I press this and I give little more pressure, I can hear the hissing sound. So this is functioning. So when any term baby require positive pressure ventilation, I will not use the reservoir. I will not use the oxygen. I do not use. So this is 21% oxygen. So when you're resuscitating a preterm baby, it is very important to use the T-piece resuscitator. This is a T-piece resuscitator, and this is being connected to the oxygen. If you connect to the blender, okay, so you can give exact concentration of oxygen. If you do not connect to the blender, you will be giving 100% oxygen. Okay. So I will demonstrate the T-piece resuscitator little later. Okay, fine. So now, fine. So now so how do I place this? I'm standing at the head end of the baby. This baby requires positive pressure ventilation. I'm standing at the head end of the baby. I have chosen appropriate size mask. I said the appropriate size mask is the one which covers the tip of the chin, mouth and the nose. And I have fixed this. How do I place on the baby? So I place this on the baby by the cupping method. Start from the tip of the chin and cup the nose. This is how I place it on the baby's face. And I hold the mask with my 2 fingers, thumb and the index finger. These three fingers are at the angle of the jaw. I lift the jaw and press the mask little down so that there is airtight seal between the mask and the face. This is most important, right? So now, at what rate I will give? I will give at a rate of 40 to 60 per minute. How do I do? I will say that mantra. Breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. When I say breathe or squeeze, I'm pressing. 2, 3 means I'm relaxing, right? Breathe, 2, 3, breathe, 2, 3. So always when I do that, I have to look at the chest of the baby to look at the chest rise. Look here, breathe, 2, 3. When I say breathe, there is chest rise. This is what I want you all to concentrate. Breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. Right. So you learned about where you have to stand, how do you choose the appropriate size mask, how to know whether this is functioning, how to place it on the baby. So now, let us now discuss. Now this baby requires the positive pressure ventilation, right? So I called Dr. Rashmi. Rashmi, will you please connect the pulse oximeter to the right hand? Okay, I've chosen appropriate size mask and placing it on the baby's face by cupping method. Rashmi, have you placed it? Okay, so I will give it a rate of 40 to 60 per minute. Rashmi, let me know after the 15 seconds. Breathe, 2, 3, 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 breathe, 2, 3. So 15 seconds over. So I'm looking at the monitor. The heart rate is increasing. The heart rate has become 70. So that means the heart rate is increasing. This is the first scenario. Then I will continue my positive pressure ventilation for 15 more seconds. Rashmi, please after 15 seconds. Breathe 2, 3. 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 So I've continued for 15 seconds. Total of 30 seconds over. Look at the heart rate. The heart rate, what is the heart rate, Rashmi? It is, I can see 135. So when the heart rate is 135, okay, hold on. Rashmi, is the baby having a spontaneous breath? Yes. Okay, baby having a spontaneous breath and the heart rate is more than 100. I'm gradually tapering and stopping. Breathe 2, 3, 4. Breathe 2, 3, 4, 5. Breathe 2, 3, 4, 5, 6 and gradually see, and if the baby requires oxygen, I will give. Now I'll come back to the second scenario. So I'm giving positive pressure ventilation. Breathe 2, 3. Breathe 2, 3. Rashmi, tell me after 15 seconds. Breathe 2, 3. 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 15 seconds over. Okay, is the heart rate raising? No, the heart rate is not increasing. It was 65. Now also it is 65. Rashmi, will you please auscultate chest and or look at the chest rise? Is there any chest rise, Rashmi?
Chest is not moving.
Chest is chest is moving. Okay, I can give a scenario of the heart rate is not rising, and now the chest, I can see chest is rising. So this is the second scenario. Heart rate is not increasing, but the chest is rising. Then also I will continue for the next 15 seconds. And Rashmi, tell me after 15 seconds, please. Breathe 2, 3. 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 Breathe. Okay, 15 seconds over. Then totally 30 seconds of effective ventilation over. Now I look at the heart rate of the baby. It is increased to more than 100. And Rashmi, the baby having a spontaneous breathing? Yes, baby has a spontaneous breathing, and gradually I'll taper and stop as I did before. Now, the third scenario can happen when I start giving a positive pressure ventilation, and Dr. Rashmi has connected the pulse oximeter with the right hand. And after 15, Rashmi, please let me know after 15 seconds. Breathe 2, 3. 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 15 seconds. 15 seconds over. Okay. The heart rate is not increasing. Rashmi, can you please look at the chest rise? Chest is not moving. Chest is not moving, not raising, and so I'm not giving effective ventilation. This is the time the heart rate is not rising and the chest rise also not there. This is an indication for ventilation corrective steps. I will do MRSOPA. I will do two at a time. One is MR. I do mask adjustment on the face. First, I'll position the airway. I do mask adjustment on the face, and I will give 5 breath now. I've done that. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2. I have given 5 breath now. Is there any chest rise, Rashmi? Yes. Yes, I can see no chest rise. No chest rise. Okay, there is no chest rise. Fine. There is no chest rise. I will go for the second corrective step. That is SO. Fine. I do suctioning. I do suctioning of the mouth. Not more than 5 centimeters in the mouth. Not more than 2 centimeters in the nose. Oh, I open the mouth and I start giving positive pressure breath. Breathe 2, 3. 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 Breathe 2. I have given 5 breath to the baby. Is there any chest rise, Rashmi? No chest rise. So there is no chest rise even after MASO. I will give the third one. I increase the pressure. Breathe 2, 3. 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 There is chest rise. Okay, fine. Now, from this time, I will start giving for 30 seconds. Rashmi, please tell me after 30 seconds, Rashmi. Breathe 2, 3. 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 30 seconds over. Rashmi, what is the heart rate? Heart rate is increasing. Heart rate is increasing. Okay, so heart rate is increasing. Okay. So you can just auscultate, Rashmi. You can auscultate. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. What is the heart rate, Rashmi? Heart rate is 120. Does the baby have a spontaneous breathing, Rashmi? Yes. Yes, baby is having a spontaneous breathing. I gradually tapering stop. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3. Breathe 2, 3, 4, 5. I'll stop it. I'll stop it. Okay, now I'll stimulate the baby and I'll look at the saturation of the baby. And if I give positive pressure ventilation for a long time, more than 1 minute, I'll shift the baby to the observational care. Okay, so where do I observe the baby? I do observe the baby next to the mother. What do I observe? I observe for heart rate, respiration, saturation, and how is the baby feeding. All that I will do. Okay, so this is about positive pressure ventilation. That's it. So, Prashant. Prashant.
Yes, ma'am. Yes, ma'am. Thank you for the wonderful presentation, madam. Yeah. Yes. Can you hear my voice?
Yes, sir.
Yeah. Yes, Prashant.
So now we will be demonstrating how to go about intubating the baby.
Yeah.
Previously, we used to look at positive pressure ventilation, and then we would teach a chest compression, and then we would come to endotracheal intubation. And as Janaki ma'am has rightly said, with the updates, 2015 guidelines as well as the 2020 updates, which has reinforced the 2015 guidelines more and more. I think it's important for us to all of the neonatologists and and pediatricians to know intubation, because they have the emphasis on intubation is more than ever in resuscitation from the latest guidelines. So I'm just running through brief things which looks at endotracheal intubation. So not much into theory, and then we'll go to demo. So when do we do endotracheal tube insertion? So when it's a prerequisite and it's recommended before we start the chest compression. If positive pressure ventilation with a mask, face mask, does not result in clinical improvement. We saw MR super demonstrated by Chandrakala ma'am. So as a part of alternate airway, we would go with endotracheal intubation if your MRSOP fails on your face mask. So the other way of looking at it is, so you're ensuring that the breath is delivered to the lung without any problems. So in endotracheal intubation, we are delivering the breath directly into the trachea and that means to say to the lungs. And also in certain situations where the baby does not breathe, and if the positive pressure ventilation lasts for more than few minutes, so the common scenario what we see is a baby who is severely asphyxiated, and you see the heart rate which is improved with your initial steps, with your positive pressure ventilation, and now you think of shifting the baby to NICU or your care or for observational care. The baby doesn't breathe, so you might have to intubate the baby at that time to shift the baby to one place to another place. Another special situation, I'm sure Janaki man will look at all that. So in case of suspected diaphragmatic hernia, we need to intubate the baby. For surfactant administration, we all know we need to, as a part of INSURE technique, we need to intubate a baby. So if there is thick secretions, like if it's a meconium and amniotic fluid, though it is not a routine, if you suspect there are thick secretions inside the trachea, so you might have to do a direct tracheal suction. In those situations, there you need to do a intubation. So these are the indications of intubations. So when we before going into the procedure as such, this is the anatomic landmarks we all should know, because these are the ones exactly we're going to visualize when we look at the vocal cords. So here on the anterior aspect or on the superior aspect of your screen is your tongue. And then you have a leaf-like structure, which is epiglottis, which overlies your vocal cord. So what we need to do is, and then below the epiglottis, you have your glottis and your vocal cord. The white structure in inverted V shape is your vocal cord, which at some times will be abducting and adducting if the baby started breathing or if the baby becomes active, or it could be abducted. And lower down, you will actually see the esophageal opening. So when you are looking at through your laryngoscope, you should be appreciating all these structures before you move ahead. So these are the equipments we require for your endotracheal tube intubation. You need to auscultate, we need to have laryngoscope, appropriate size blades, endotracheal tubes, you need to have a measuring tape, you need to have a suction catheter, you need to have scissors, and probably if you want to secure a ET tube, you need to have a plaster. So the endotracheal tube, which is recommended for all newborns, at least for now, is a non-cuff tube, which has a vocal cord guide, which you are seeing in your right side of the picture. So how to choose our endotracheal tube? So most of the recommendations say that you need to put it up in your resuscitation area so that you won't forget it. If you can remember, it's well and good. Any baby whose gestational age is less than 28 weeks, you're going to use 2.5 size. 28 to 34 weeks, you're looking at 3 size ET, and greater than 34 weeks, you're going to use 3.5 size ET tubes. So based on weights, also you have this cutoffs, but unfortunately, I mean, during resuscitation, we won't be looking at it. Probably a guess would also help you. Below 1000 grams, you're going to use 2.5 size ET, 1 to 2 kilos, 3, and greater than 2 kilos, it's 3.5. So I don't think you need to routinely keep your 4 size ET tube in your resuscitation kit. So positioning the baby is something which is very important. As I told about the anatomy inside, you also need to look at the airway anatomy outside. So if you look at it on the left side of your, the left figure represents a baby who's just lying on a flat bed. You see the line of sight when we look at it on a straight line. So we are not able to look at your vocal cords. So the recommendation is to extend the neck. So if you overdo it, you might also not be able to visualize the larynx. So the correct position is slight extension so that you can visualize the vocal cords. So here this straight line is obstructed by the tongue, but when you're looking at when you're inserting a straight flight, so your tongue will go up and so that you actually can visualize the vocal cords. So getting ready for intubation, you need to stand at the head end of the baby, and the right side of the figure shows how to hold the laryngoscope. And we always keep telling about this. The Miller's laryngoscope blades have been manufactured in such a way that it can only be used with the left hand, even if you are a left-handed person or a right-handed person, immaterial of it. You're gonna hold the laryngoscope in your left hand, and while inserting the tube or while handling the tube with your right hand. So intubation procedure. So from the right angle of the mouth, you slightly you go in, push the tongue to the other side, and go up till you get the vallicula. Vallicula is nothing but the space between the epiglottis and your tongue, base of the tongue. So you're going to go above the epiglottis and gently lift up, and then you visualize and you then go to the midline to visualize the structures here. So I'm going to demonstrate how exactly to do it. And then the other most important thing we need to understand is the technique to lift the laryngoscope to expose the larynx. We said that the base of tongue or the tongue obstructs the visualization. So we need to kind of lift the tongue which is obstructing your view. So here you see the left hand side, the correct maneuver in which you are lifting the laryngoscope, and the right side which shows an incorrect one. So where you see the laryngoscope is being tilted. Okay, so it's like tilting here. So here in the first one, it is actually pushing it up. All right, we will look at it in the demonstration. So these are the things which you need to be careful of when you intubate a baby. So suppose if you don't visualize, if you can't visualize the vocal cord, so what are the things which you're going to look at it? So this diagram is something which most of us would have seen, or which you're going to see if you are not inserted the laryngoscope plate into the correct depth enough. So what you're actually seeing is just the base of the tongue here. So if you go beyond your vocal cords, or if you insert it too deep, this is what you're going to see. The aperture what you're seeing is an esophagus. All right. So you're not seeing any aperture here. So the best thing is, or if you're not able to visualize, there might be secretions for which you need to do suction. Okay. These are the three things you need to remember when you can't visualize the vocal cords or the anatomy which I just showed you in my second slide. So while I have seen the vocal cord and I have inserted the endotracheal tube inside the vocal cord and it has gone through the vocal cords, so the right hand will go and hold the endotracheal tube against the hard palate as actually shown in this figure, and then the laryngoscope is lifted off slowly. So for us to the time allotted for an intubation attempt, remember it should not exceed more than 30 seconds. If you have failed in securing the endotracheal tube, you're going to abandon the procedure and continue with your bag and mask ventilation. So how do you confirm the position? So you will ask your helper to auscultate the axilla, both sides, to see if the air entry is equal. And it's also good practice to auscultate the stomach to see if your endotracheal tube has got displaced into esophagus and you can hear the sound in the stomach. So now the depth of insertion. So we talked about what is the endotracheal tube size we need to choose, and how far we should insert the endotracheal tube is based on this thing called nasotracheal length. So from the middle of your columella, nasal columella, you measure the length up to the tragus. So on the extreme right side, you're actually seeing the nasotracheal length being measured, and you need to add 1 centimeter to it. and this is the distance at which you have to keep your endotracheal tube and fix it. So fixing the endotracheal tube, so you're going to use a plaster, cut it 3/4 as actually shown in this figure. It look like a pant. So one leg of the pant will go onto the lips, and the other leg will actually encircle the endotracheal tube, and this is secured as shown in the right side. All right. So now let's move on to the demonstration. So for demonstration purposes, I'm using an unsterile or disposable gloves here. All right. So these are the things you would want to keep it ready. One more thing. So this is your laryngeal handle. And you have different sizes. So for example, I have actually chosen one side for all down breathing. Even I am going to down breathing here. I'm actually using this kind of Miller's breathing. The numbers would be written over here. So if you can see clearly, it's written 1 here, and for preterm breathing, 0, but extreme preterm breathing, you want the 0.
Prashant, we cannot hear you. Prashant, we cannot hear you.
Prashant, kindly unmute yourself. Prashant, kindly unmute yourself. Unmute. Prashant, unmute.
Prashant Gowda, can you call Chandrakala's mobile number and tell?
I'm calling, sir. I'm calling. Prashant, kindly unmute. You have muted yourself. Can't hear. Prashant, you have to unmute.
Prashant Gowda, you call Prashant YN directly to his mobile.
And I'm calling directly, sir. He's not receiving the call. Both
Otherwise, Chandrakala.
She's also not receiving the call. Prashant, kindly unmute. You are not, you have muted. Kindly unmute and speak. Yeah. Prashant, kindly start from beginning. We didn't hear anything.
Okay, done.
And kindly keep the camera stable. Don't move it too much.
Keep the camera stable.
Is it audible? Is it audible?
Yeah.
Sorry, we did not realize that it was not audible.
Yeah. You start from beginning. Yes. Wear hands free to your thing, hands free so that you hear what we are telling.
Laryngoscope handle, and these are the blades, these are the parts. And I showed different sizes blades. You have one size, you have 0, and you also can have 00 blades. So for now, maybe we will use 1 or probably 0.
Audible.
Prashant, your voice is not clear. Can you kindly use hands free? Can somebody tell him to use
Sir, your
hands free?
voice is not clear.
Prashant, your voice is not clear. Can you use hands free, cordless hands free?
So,
Can you put it on your ear and speak?
what I'm going to do is, you have a groove in your a pair of batteries which are kept ready, and you have different size ET tubes. All right. Put it. So I just told you how to choose the ET tubes.
Sir wants you to use hands free.
Oh yes. Yeah. Can you all hear me?
Yes, yes. Now it is better. Go a little slow. And the
Okay,
camera, whoever is holding
Sure,
now,
sir.
don't shake too much.
Yeah.
Okay.
Sure.
Yeah.
Sure. Okay. So you need to stabilize the camera. Sure, man. So here we have kept three size ET tubes for you to make the difference. So this is a 3.5, this is 3, and this is 2, 2.5. And we are supposed to keep only 3 size ET. 4 is not recommended no more. So how do you look at your ET tube sizes? It will be written below this. All right. So you should not take the ET tube, open it and keep it. So we all know that it actually comes in a sterile manner. So your helper or you, when you're preparing, you're going to open it without touching the ET tube, and you're going to keep it ready on the right side of the baby, because you're going to handle your ET tube from the right side. And the other things which you need to also keep ready is your tape, measuring tape, because to measure the nasotracheal length, we need the tape. We need to have a plaster. We need to have a plaster. If you can see this, it's actually cut 2/3, and it is in a shape of a pant. This is ready. So with this, we should be able to ventilate a baby. And mind you, one of the causes of your not visualization of your anatomy is your secretion. That's why you also should make sure that your suction is working and your suction pressure is kept between 80 to 100 millimeter of mercury. So holding the laryngoscope, so whether you're right or left-handed fellow, so you're going to hold it with your left hand. So this is how you're going to hold it. You need to hold it gently, not very firmly like this. Okay. So if you're intubating it well, you should not find any difficulty in lifting the tongue of a newborn. So that's why you're going to hold it very snugly, and probably you might not use so much of force. All right. So this is how we hold a laryngoscope. And the second thing is the position of a baby. If you can see this baby over here, from side you project down. If you see the baby is just slightly extended, not too hyperextended, or it is flexed. So this is how we're going to position the baby. And with the left hand, from up you come, from the left hand. So the first thing is you have to come, insert your laryngoscope onto the right angle of your mouth, and then take the tongue a little to the center. Once you have gone to the position, you have to go to the midline, and then you see if you can visualize the vocal cord. All right. So what I'm appreciating over here is the epiglottis. Stabilize it. So what you're appreciating here is your epiglottis, and you're actually seeing your glottis also, the white 2 lines. So this is a perfect thing for me. So without changing the or looking away, I'm going to go back. I'm going to take the endotracheal tube from my right hand and go from the right angle of mouth without obstructing the view. If you can see sometimes you might go like this. This will obstruct the view. The way you insert your endotracheal tube is from the right angle of mouth, go inside, Once you have gone, secure, take your laryngoscope out while your other hand is held against the hard palate. So once the secure is, once it is secure, we need to know how much, at what length I have to secure it. So I'm going to ask my help to measure the nasotracheal length. So Nikit is measuring the nasotracheal length. So as you can see, from the middle of the nasal columella, he's measuring up to tragus. What is the length, Nikit?
8.5.
It's 8.5 centimeters. So 8.5 plus 1 is the number at which I'm going to put it. So 9.5. So I am at 9 and 9.5 now. So this is how I'm going to secure my ET tube now. So once it is done, it's also important for your helper to auscultate to see if it is having equal breath sounds. As I said, so he'll be checking both the axillas, left as well as right, and also the stomach. So you need to ask him whether he can hear the equal sounds on left and right axilla, and no sound in or no sound or less sounds in the stomach, and that reassures that I'm in the correct position. So after that, I'm gonna secure the endotracheal tube. So for this also we need to have a helper. So the upper leg goes onto the lips, go up, and the other leg will encircle the ET tube. So once it is done, you might take your thumb off. So this is how you successfully intubate a baby. Yeah, this is it from now. Chest compression, the other baby should come.
Prashant.
Chandrakala, you can start.
Madam, kindly unmute. Kindly unmute. 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 Unmute.
Yes. Yeah. Can you hear me now?
Yes, madam. Yes, madam.
Yes. Yes. Thanks. Okay. So now we will move on to the chest compression. Remember, the endotracheal intubation is not the next step in any of the steps in the flow of NRP. So endotracheal intubation is done whenever the ventilation is not effective, right? So that's an important point you all need to know. Now, so what is the indication for chest compression? So now you look at this. So after 30 seconds of effective positive pressure ventilation, and when I check the heart rate of the baby, if the heart rate is less than 60 beats per minute, then that is an indication for chest compression. The most important thing you all should know is, before chest compression, some 3 important things you need to consider. That is, intubate the baby if it is not already done. Right? So you need to ensure the ventilation is good before chest compression. 1. Second important thing is, when you are giving chest compression, you need to give 100% oxygen. So how do you give 100% oxygen? So you need to connect oxygen and the reservoir. You need to attach oxygen and the reservoir to the self-inflating bag and give 100% oxygen. Or if you're using a T-piece resuscitator and a blender, if you are using, you turn to 100 FiO2. So it is important to connect the ECG monitor at this point. Now, so indication of chest compression, I already have told you that heart rate is less than 60 beats per minute after at least 60 seconds of positive pressure ventilation. That is effective. How do you know it is effective? you can see the chest rising or you can hear the airflow. Okay, so I'm not going to the much theory of the chest compression. So as all we know that still the myocardium is depressed because of poor oxygen levels and because of acidosis. So there is decreased perfusion of the coronaries. So hence low cardiac output. So it is very important that we need to compress the heart between the sternum and the spine. So to improve the perfusion of the lungs. Now, what are chest compression? It is a rhythmic compression of the sternum. So that compresses the heart against the spine. It increases the intrathoracic pressure and circulate blood to the vital organs. Now, so this is the phase, different two phases of chest compression. It is compression and release. Compression and release. Now, so when you want to do chest compression, you need to have minimum 2 people required. When you are doing positive pressure ventilation, you have a second person coming in. The same person can be there, or you can ask one more person to come. So you can have minimum 2, ideally 3 people for chest compression. So now, very important for all of, why 3 people? So the positive pressure ventilation and the chest compression has to be done in a coordinated manner. It should not be done simultaneously. Now, so where do you stand when you are giving chest compression? Ideally, when you are giving chest compression, you would be standing by the side of the baby. And we know that when the baby already required chest compression, he might require medication. So we need to have a place for the person to have an intravascular access. So that is very easy if he's standing by the side of the baby. So for giving way for the person to have intravascular access, you have already intubated the baby. The person who is giving chest compression will be standing at the head end of the baby like this, and the person who is giving positive pressure ventilation will be by the side of the baby. Now, where do I do what is the place for chest compression? The chest compression is done in the lower third of the sternum. So it is, you draw an imaginary line on the nipple just below the imaginary line drawn on the nipple, and the place just below that is the place for giving chest compression. Remember, when you are giving chest compression, you should not hurt xiphoid process. Otherwise, you will be injuring the underlying structures. Now, so you understood now the location for chest compression. Now, so what depth I need to compress the chest, compress the sternum? It is 1/3 the anterior posterior diameter. Right? Now, so we have already discussed what is recommended is 2-thumb technique. That is recommended even in 2015 and also in 2020 recommendations. Also, there is 2-finger technique that is not recommended. Now, so we know that the 2-thumb technique is recommended, and where do you place your thumb? So it is in the lower third of the sternum, and remember, you need to flex the distal interphalangeal joint. Either you can keep by the side, the 2 thumbs by the side, or you can just see one above the other. One above the other. So you learn where to place and how to position. Ensure your other fingers is encircling the baby's chest. Now, so we will come to that little later. Now, what is the rate of compression? So how much I need to compress? Now, we are giving in the chest compression more importance for compressing the heart mechanically. So it is 3:1, and it is 90 compressions per minute and 30 ventilations. Here, remember, the ventilation is less as compared to chest compression. So 3:1 compression, approximately it is 120 events per minute. Now, what is that mantra? What is that rhythm we are doing chest compression? 1 and 2 and 3 and a breathe. 1 and 2 and 3 and a breathe. This is what you are going to call out. Who is going to call out? The person who is giving the chest compression is going to call out this rhythm. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. When I say 1 and 2 and 3, the number, you need to compress and you need to relax. Right? So remember, 1 is shorter than and. 1 and 2 and 3 and breathe. Right? So this is what you are going to sing. 1 and 2 and 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe. So when you are relaxing, when you are saying 1, you are compressing the chest, and you are relaxing. And keep it. Place your both thumbs on the chest. Don't take away. Otherwise, it is very difficult to relocate the position. You will be wasting your precious time. And remember, you need to give 100% oxygen. So now, how long I need to give chest compression? It is not 30 seconds, it is 60 seconds. I don't want to interrupt in between while giving chest compression. So I continuously give chest compression for 60 seconds. At the end of 60 seconds, I will check the heart rate of the baby. Very important thing is what is the preferred method for assessing the heart rate of the baby is ECG monitor. Right? Or you could use stethoscope, or you can use pulse oximetry, but it may be difficult with them to know the heart rate of the baby or to hear the heart rate of the baby, right? So now, after 60 seconds, after 1 minute of the coordinated chest compression and the positive pressure ventilation, I check the heart rate of the baby. If the heart rate of the baby is more than 60 seconds, and that is an indication for stopping chest compression and then continue positive pressure ventilation at a rate of 40 to 60 per minute. That is breathe 2, 3, breathe 2, 3, breathe 2, 3 and gradually downgrade. Right? After again 30 seconds of positive pressure ventilation, check the heart rate of the baby. If the heart rate is more than 100 per minute and the baby has a spontaneous respiration, then gradually taper positive pressure ventilation and stop, then continue giving oxygen by looking at the saturation. Remember, you are giving 100% oxygen when you are giving chest compression. Gradually reduce the concentration of FiO2 if you are using a blender based on the saturation, right? And when the saturation is normal, when the saturation is appropriate for the age of the baby, then take out oxygen and this baby would go to post-resuscitation care. Where do you do post-resuscitation care? The baby will go to NICU, right? Now, so what can happen? So now I give a scenario after the 1 minute of the coordinated chest compression and positive pressure ventilation. I give a scenario that heart rate is more than 60. I stopped chest compression. Now, what in case the heart rate is less than 60? So after 1 minute of effective coordinated chest compression and positive pressure ventilation, if the heart rate is less than 60, what is the next step? I will go for medication. The next step would be medication drugs. But before jumping to medication, see all the previous steps you have done, it is correct. For example, whether you have intubated the baby, whether the air entry is equal on both the sides, whether you have connected to 100% oxygen, whether the depth of compression is adequate, or whether you are coordinating the chest compression and positive pressure ventilation in a coordinated manner. See all this once, and if you have done all this correctly, then move on to the next step, that is medication. So we will go on to now the demonstration of a chest compression, then we'll take up medication little later.
Yeah.
Okay. Can you hear me?
Yeah, we can hear you, madam. If you can use hands-free, it is better.
Hands free.
We need to spotlight Rashmi. Spotlight Rashmi.
Can you hear me, Dr. Prashant?
Yes, madam. Yes, madam. Yes, madam.
Right. So the prerequisites, so this baby meets the indication for chest compression. So already I've intubated. So this is a self-inflating bag. This is I've connected to 100% oxygen. There is reservoir and there is oxygen. So how many people I need? I need minimum 2 people for chest compression. So can you come? Can you help me? Okay. So because this baby is already intubated, I'm giving chest compression standing at the head end of the baby. Dr. Rashmi is giving positive pressure ventilation. I'm doing chest compression at a rate of, so this is the place. How do I recognize this place? I gently move my finger along the sternal border and subcostal margin and identify xiphoid process, and just above the xiphoid process, just below the imaginary line between the nipple is the place for chest compression. So I use 2 thumb technique. So I'm flexing the distal interpharyngeal joints and I'm giving chest compression at a rate of 3:1. The ratio 3:1, 1 and 2 and 3 and breathe. Come this side. Hold perpendicularly now. Okay, 1 and 2 and 3 and breathe, and 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 1 and 2 and 3 and breathe. Can you please tell me after 60 seconds? 1 and 2 and 3 and breathe in. 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 So 60 seconds over. Okay. So what is the heart rate of the baby? 80. You check the stethoscope. Please auscultate. Please auscultate, Niket. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. So I'll just stop it for a while. I look at the heart rate of the baby. The heart rate is?
Heart rate is 80.
Heart rate is 80. Now it is more than 60. I will stop chest compression. I will continue positive pressure ventilation rate of 40 to 60 per minute. So breathe 2, 3, breathe 2, 3. Please tell me after 30 seconds. Breathe 2, 3, breathe 2, 3. Breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3. 30 seconds over now. Okay, so what is the heart rate? 120. Okay, is the baby having a spontaneous breathing?
No.
Baby is not having a spontaneous breathing. I'm continuing. What is the saturation?
Saturation is 81.
Saturation is 80. Now I'm giving 100% oxygen. I will reduce the FiO2 to less than that. I continue positive pressure ventilation for another 30 seconds. Breathe 2, 3, breathe 2, 3, breathe 2, 3. So 3, see, I'm reducing here FiO2 to now it is how much? It is 40%. And even though the reservoir is there here, so it is FiO2. I'm delivering for 40% FiO2. Breathe 2, 3. Please tell me after 30 seconds. Breathe 2, 3. 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 30 seconds over. 30 seconds over. Yeah, that's 30 seconds over. Is it?
We might want to shift the baby to NICU.
We will shift the baby to NICU. Fine. Okay. So shall we make arrangement for shifting? Okay. Fine. Stop.
So once we have done with the chest compressions, let's move on to the next step of the resuscitation. That is medication administration. Right? Okay. So going on to medications. So as we know that this is where the medication algorithm belongs. So the last one is the medication step. If you can see the highlighted with the green box over here. So what are the two things we require for resuscitation? It's only two things, very easy to remember. One is epinephrine, and the other thing what we require is normal saline. So the other medications which we classically used to say use before is no longer recommended. Although in special circumstances you might still use naloxone and probably other blood products if required. All right. So for keeping things simple, so we're going to use only epinephrine and normal saline. So when do we administer epinephrine? So if the baby, so we always need to remember that there are very minute percentage of babies who will go on to medications. And we heard from the talks of Sahana ma'am, Janaki ma'am and Chandrakala ma'am that if we give good positive pressure ventilation, the going down into the flow chart is not necessary. So when it is absolutely necessary, if the heart rate remains below 60 beats per minute, even after at least 30 seconds of positive pressure ventilation, which moves the chest, and after 60 seconds of chest compression coordinated with positive pressure ventilation using 100% oxygen. So every point in this thing is valid. We need to move the chest, inflate the lungs, give 60 seconds for 30 seconds, 60 seconds of chest compression coordinated with PPV with 100% oxygen. Then you think of moving on to medications. So in India, epinephrine is available as 1:1000 concentration. So what we need, the epinephrine, what is recommended is to use 1:10,000 dilution. So how do we do it? We take 1 ml of 1:1000 dilution of epinephrine and mix it with 9 ml of NS. So it becomes 1:10,000. So this is the concentration we want to use. So how do we give it? So we need to look at intravascular route, that is intravenous or intraosseous. Endotracheal, administration through endotracheal tube is not recommended. So, but if you are getting delayed in getting an IV access or intravenous access or intraosseous access, you can give through endotracheal tube also. So the dose is the prepared 1:10,000 dilution epinephrine should be used in the dose of 0.1 to 0.3 ml per kg of this 1:10,000 diluted epinephrine. And if you are using through endotracheal tube, you might have to use large doses. So your dose will go up to 0.5 to 1 ml per kg. So how do we administer it? We should administer as rapidly as possible. And we need to flush with 0.5 to 1 ml of normal saline. And if we are giving through endotracheal tubes, we need to give positive pressure breaths, which distributes the epinephrine into the lungs. And how often to repeat? We repeat every 3 to 5 minutes if the heart rate remains less than 60 beats per minute. So having said that, so the point we need to remember is while we are giving administering medications, we should not be stopping your positive pressure ventilation and chest compression. In other words, we need to continue the chest compression coordinated with positive pressure ventilation. All along, we are giving your medication as well as waiting for the response to occur in 3 to 5 minutes. So the other medications which we might have to use. So we already saw it from Janaki ma'am's presentation. If the baby is not responding to any steps of the resuscitation which are assumed to have gone well, or you check that it has gone well and has signs of shock or any history of acute blood loss in the mother. So there comes the importance of history in the mother, taking history in the mother. So crystalloids are preferred. So normal saline is what we prefer. In case of suspect anemia, if you have provision, you can also go ahead with O-negative packed cell red blood cells. And the route is intravenous or intraosseous. And the preparation, we need to label a syringe which is 30 to 60 ml syringe. And administration, we need to give 10 ml per kg over 5 to 10 minutes. All right. So this is about volume expander. So establishing rapid intravascular access is a must. So we are not going to look into how much we will insert. So this is just to show how the equipments are actually prepared on a whole towel in a sterile manner. If you can see that the umbilical area is prepared here, and the right side actually shows the anatomy through which your UVC goes in. So so the procedure, we know that we're going to tie the cord tie around the skin. and we're going to cut it with a sharp scalpel blade, approximately 1 centimeter above the skin. And then once it is out, we're going to identify the vein and the arteries, and then and then put your umbilical venous catheter inside it, only just to the point that you can aspirate the blood, or if there is free flow, and then you're going to flush the catheter and keep it at that. Most of the instances, you might the catheter should go only 4 to 5 centimeter, and you would definitely get a backflow. So this is low-lying UVC. You need to remember that. So this is how we administer epinephrine. So we need to have a 3-way stopcock, and then you have your normal saline on the way to your umbilical catheter, and from the side port you're going to administer epinephrine. So once the epinephrine is administered, you're going to flush it with 1.5 to 2 cc of normal saline immediately. So this is how you demonstrate. This is how you administer epinephrine. So even after epinephrine, with additional features of shock or antenatal history of hemorrhages, if you anticipate, so this syringe will be replaced by your syringe which has normal saline. So with this, let's get on to the demonstration. Take this. Yeah. Am I audible, sir?
Yes. Audible. Go ahead.
Yeah. Yes. So I know Sahana ma'am actually demonstrated what all we need to keep ready, just to kind of do a revision. So we need to have a normal saline. We need to have epinephrine. These are the only 2 things we'll require, light. And then we need a syringe. So we usually call it a stock solution, which we need to have 10 cc syringe for this. So here I've actually filled 9 ml of NS already, and 1 cc syringe to take adrenaline, and also to 1 cc syringe to push adrenaline, and then or 20 cc syringe probably is required if to administer NS bolus, which is also ready. This is the umbilical venous catheter, which you get. You might use umbilical venous catheter if it is not a 5 size RT also could be used. So here in this situation, I'm at a 3-way and actually keeping it ready with normal saline flush, so which is connected to a 2 cc syringe. So this should be kept in a very sterile manner. So just for demonstration purpose, I've opened it and kept. And things which are required for catheterization is your cord tie, which I kept here. So you have chlorhexidine. You might want to use better, and you have to insert, and probably all right, and a whole towel which is sterile. All right. So, and also if you want to choose, if you choose to keep the catheter intact, so you might have to have plasters also for securing the umbilical venous catheter. So with this, so how I'm just going to demonstrate how I'm going to prepare 1:10,000 dilution. The epinephrine, what you're actually seeing is 1:1000 dilution. So I'm going to take this 1 cc. All right. Maybe you can use this, or the 9 ml of pre-filled NS. I'm going to take it to make it to 10 cc. With this becomes adrenaline 1:10,000 dilution. So the better way of keeping it is like, when you are working in an NICU or labor room, to keep this as a stock solution and put it off in a tray so that it can be used anytime, rather than doing it for each delivery, and probably you'll have to close it in a style manner. If at all that's the time we need to prepare it again and keep it. So not at the time of resuscitation. All right. And rest of the things I have actually, I've just told you. So now I'm I'm going to tell you about how the sequence works. So now this is a baby who received effective positive pressure ventilation for 30 seconds and then has received 60 seconds of coordinated chest compression with positive pressure ventilation after intubation with 100% FiO2. And this baby doesn't seem to be improving. All right. So the person who is actually doing chest compression and positive pressure ventilation will still remain there, and the other person comes in. So when the other person is called, get the instrument. So while the chest compression is actually going on, so this is the importance of positioning while we are resisting. You see that the person who is handling the airway is onto the right side. The person who is handling the chest compression is at the head end, and this area will be for the person who comes in for medication administration. So here I'm actually putting a whole towel here, which is sterile, and kept everything ready for umbilical venous catheterization, scalpel blade. So this is my catheter, which is sterile, a blade which is open, and I also have my chlorhexidine. So while the chest compression, you 2 and 3 and breathe in, 1 and 2 and 3 and breathe in. So this mantra has to keep going on. There should not be any obstruction. The other person who is coming for medication is actually preparing it now. So with the chlorhexidine, I'm using chlorhexidine here. You might want to choose a betadine and a normal saline. So the umbilical cord is actually getting prepared. So I'm going to use it thrice. This can vary according to your protocols. So once it is ready, so I'm going to drape this. Continue. Drape this whole towel, and now I'm cutting the umbilical venous line. So once it is cut, I've taken it. So you might want to use a cord tie if it is bleeding. In this case, I'm not using. And once it is done and secure, I'm going to insert the catheter inside. Tie is not required. So until it is gone in, and once it is, now I see that the physis is gone. I gently aspirate. Once I see the backflow, I'll flush it and keep it. And this is how, and now I'm going to attach my adrenaline. So this baby appears to be 2 kilos. I'm going to administer 0.2 ml of stat. I'm administering 0.2 ml of adrenaline, 1:10,000 stat, followed by flush of followed by 1 cc flush, and I've closed. So if you can see that the medication is being administered, but the flow of things is not interrupted. As you can see, the chest compression is going on with coordinated positive pressure ventilation. So I'm not gonna stop it. So we're gonna do it for a whole while and check for the heart rate again. And we might have to.
Wait for 1 minute.
At least we'll have to wait for at least 3 to 5 minutes to look at the action of epinephrine. If by 3 to 5 minutes, if the response is not achieved, then the same thing would continue. We can re-administer the epinephrine along with the normal saline, and the resuscitation goes on. And even after 20 minutes of no heart in a baby, warrants that says that the resuscitation is needs to be abandoned, or if there is any response in 3 to 5 minutes. So if the heart rate is more than 60, so we can stop it. All right.
The heart rate is 80 now.
So now that they're saying that the heart rate is 80, we have stopped chest compression, but you can see the positive pressure ventilation is actually going on. So while the UVC is in place, so once it is okay, so we're going to secure the UVC.
So 30 seconds.
We can actually secure the UVC, or we might take it out.
So 30 seconds over. 30 seconds over. Positive pressure ventilation. What is the heart rate of the baby? So just check.
So the heart rate seems to be around 80.
Heart rate is 80.
80. The baby has not come back to the breaths again. So we will continue positive pressure ventilation and take a call on shifting the baby to the NIC. Okay. Thank you.
Yeah, Dr. Prashant.
Yes, sir.
Yes, sir. Yes, sir.
Yeah, Prashant, well demonstrated, well explained. Chandrakala, well explained. Really very happy. Okay, now because we have almost till now 18 questions are there. People are waiting. Okay, can we move to Dr. Janaki, madam? Yeah, Prashant Gowda, can you call madam? Dr. Janaki.
Yeah. I'm here. Okay.
Okay. Dr. Janaki is online.
Yes, Dinakar, we are here.
Yeah, madam, please go ahead and start. Because
we'll start the preterm resuscitation. Just give me 1 minute.
So just
okay.
Just because we are short of 8 minutes already. Please start early.
Yes, we are starting now.
Yeah. Because we have already got 18 questions. Really, it is excellent questions people have asked, especially for Dr. Sahana, Dr. Prashant, Dr. Chandrakala. All tricky questions are there. I don't know, because I think so you people are the masters. You are able to do it. So over to Dr. Janaki.
Madam, Vinod, that I have to make a spotlight.
Yes, sir. Yes, sir. Yes, sir. Same thing, sir. Yeah.
Okay. I'm making it stay. Give ma'am hands free. Have you given to ma'am?
Yes, sir. Yes, sir.
Okay. Start.
Hello, good evening. We are here. We are called for the resuscitation of a 28-weeker who weighs only 900 grams. Mother had problems of severe PIH, and the delivery is going to take place probably in the next 15 to 20 minutes. So we have reached the delivery room about 20 minutes early. Since this baby is a very high-risk neonate, we need to check on a lot of things, our personnel, our equipment, and everything else. First, let me gather all of us are count and we are gloved, so total asepsis is taken care of. Next, let me form my team. Let me introduce to you my team members. He's Dr. Naresh, he's the neonatologist. We also have here Sister Manu. Sister Manu is the senior staff nurse of the NICU, and the other neonatologist, Dr. Vinod. So please help me with the resuscitation. Let me give you some role assignment so that we don't have any confusion. As soon as the baby is delivered, I take care of the thermal control. Manu sister, please hook on the pulse oximeter to the right upper limb and also help us in the ongoing monitoring and assessment. Okay. Next, Naresh, you will take charge of the ventilation. And if this baby requires medication, Vinod, please come in. You need to help us with the chest compression and medication. So first, let's look at the checklist. We have an excellent checklist, equipment checklist, which is kept here. But what I would like to focus is in this baby, because this is going to be a 900 grammer and an extremely low birth weight neonate. The most important thing we need to do is equipment for thermal control. So first, let's look at the ambient temperature. Naresh, can you read off the room thermometer, the room temperature, please?
It's reading around 26 degrees.
Oh, super. Just wait for this baby. So we have an ambient temperature of 26.9. Next, the important thing is I've got the warmer on. And this warmer, as you can see, is under 100% heater output. So that we literally and figuratively give a warm welcome to the baby. I also have a heated mattress under the baby. Of course, we can't keep the baby on the mattress, so the mattress is covered with 2 blankets. Number 4, we also have a polythene bag or a polyethylene bag to receive this baby. What I would like to tell you